Good morning to all. Namaste and a warm welcome to all doctors, stakeholders, and
It's been a long time we are doing our Rasaayanam online session through Zoom meetings in every Sunday. It's been a great success for such a long time, and we were able to deliver almost 250 episodes of Aachaara Rasaayanam utilization. So through this, everyone is gathering knowledge from different ideas across different parts of India. And we are happy that as a Sitaram team to contribute to Ayurveda through this Aachaara Rasaayanam program. Today I also get very happy to launch our new products. This is Fresh Start tablet, which is used for an
daily problems of constipation. So in nowadays, it is very common that due to the lifestyle and different sitting jobs, many of them are facing constipation as a daily habits. So this Fresh Start is a tablet which can be used for daily usage, and it is free from chemicals or any harsh things. So it is not an habit forming product also. And we are also happy to introduce our one of the other products is deep sleep. Insomnia is also a common condition in nowadays with because of the lifestyle change and food habits change. It is common among youngsters and even in old people, and it is associated with the different diseases also. So with the formulation of deep sleeps and the clinical studies which we have done, we are happy that it is having a positive result almost greater than 95% in patients. So we will bring this product to the online stores and hypermarts, particularly to the daily usage of the over-the-counter usage for these patients. And it can be also be prescribed by the doctors because as per the clinical trials which we have done, it has been shown that's a good results, and it is safe and free from any chemicals, and it is based on herbal formulations and micronutrients. So it is also contributing to the positive outcome of the patients. So we are happy to launch these products today, and also the offline session of Aachaara Rasaayanam. Today's morning session will be taken by Srival Sir. Dr. Srival Sir is very known figure in Ayurveda. He has been taking Marma practical classes for such a long time, and many of them maybe have been attended his class in past. years also. So we are very happy that Srivalsan sir is here, and we, as a part of Sitaram, we welcome you, sir, for this CME initiatives. Thank you, sir. And today also we were happy to have our director, Dr. Vignesh Devraj, sir. He is also happy to attend today's offline program to contributing to this Aachaara initiatives. Aachaara CM initiatives also one of the brainchild of this our directors. So we welcome you from behalf of the Sitaram Ayurveda family to this function, sir. Thank you very much. And we are also happy to have our CGM, Dr. Sandeep Via today, and he is also contributing. Even he is not an Ayurvedic doctor, he is attending the Aachaara regularly, and I think he may be getting knowledge very much with this Aachaara. We are happy to have you, Sandeep, here. And today also we have our GM Business Development, Rupesh, and he's also be in touch with doctors regularly, and he may be the end-to-end point from Sitaram to the end customers like doctors. So we are happy to have Rupesh today. In behalf of Sitaram family, I welcome all and each of them to this function. I hope these functions will be fruitful to you and to gather knowledge. And today we have two sessions. The second session will be taken by Dr. Kannan V. He is the ortho in District Hospital Kollam, and he will be also demonstrating practical bandaging POP in the afternoon session. Hopefully that session also be fruitful for everyone. I also welcome Dr. Kannan V to this function also. Thank you.
Moving to the inauguration ceremony. For inauguration ceremony, led by none other than our Dr. Vignesh Devraj, Director of Sitaram Ayurveda, whose leadership continues to inspire excellence and innovation in Ayurvedic healthcare. For few words, over to you, sir. Doctor.
Very welcome. Thank you all for today is a Sunday, and you all choose to come here instead of going for a movie. That just shows your commitment to learn. And I have one small request as a respect to our beloved Srivatsan sir, if you can sit in the front seat. I remember when I was studying BMS, I always want to go to the back seat because I was worried, will somebody ask any slokam, and if I don't answer, will they make me stand out? Such a thing is not going to happen because we have this respected sir after a long time. Please, somebody sitting behind, please do come in the front. The reason we are not going to ask you any questions or anything, this is just to improve the energy, because as a speaker, having the empty seats in the front row, it's just not respectful. So please don't worry, please do come. Thank you. And you will actually learn more when you are in the front seat. So thank you all for coming, and Srivatsan sir, thank you so much for accepting and coming for this. Actually, Srivatsan sir, in our community of doctors, we call him an endangered species because we want more of his knowledge to be transferred to the next generation that are coming. And one of the reasons why we started this Aachaara Rasaayanam, 2006, when I was doing my BAMS, I went to attend a conference in Mahabalipuram, which was done by one of Dr. Srivatsan sir's student, who is also nephew of Dr. Krishna Kumarji and Dr. Ram Kumar. In that conference, it was mostly Western people who came and attended this conference, like people like Dr. Deepak Chopra, Dr. Robert Svoboda, and they were coming and discussing about how Ayurveda can change life and what is the power of Ayurvedic lifestyle, dinacharya. And these classes were actually taken by Westerners. And a lot of Indians were also there, loads of foreigners were also attending this conference. And attending that conference was a very eye-opening moment for me. Because on one hand, when I was doing my BMS, I was in Pankaj Kasturi Ayurveda College in 2002, I joined. At that time, whenever we were studying, there was a lot of, whenever we joined, at the time of joining the first year, many people were discussing, I did not get MBBS, that's why I joined BAMS. This was one of the things among my classmates. And then, when I went for this conference, people were saying, okay, suddenly I was just talking to one Indian expat, living abroad, but he started getting very much into Ayurveda because he was struggling with serious headaches whenever he takes a flight. And he realized after starting Nasyam, no ENT specialist could solve what Nassim changed for him. And after that, he started believing the power of Ayurveda, and he realized there is something new into this, the world is yet to understand. And I was just having a conversation with him, then I was telling, in Kerala, actually, a lot of our Ayurvedic doctors, we actually look up to allopathic doctors somewhere. This is one thing that we look up to. I think Ayurvedic doctors are like the leftovers of whatever we couldn't get. He said, yeah, that is a possibility, but as you see, he made a very profound statement. He was telling, as the quality of life in a community goes better and better. When I say quality of life, what I mean is, when the poverty levels come out, when the quality of life is getting better. Now, in Charaka Samhita and Ashtanga Hridayam, we read about there are only two types of treatments, right? Brahmanam and Lankanam. And if you look at it, there are two types of diseases, Santarpana Vyadhi and Apadarpana Vyadhi. Now, what he's telling was, as the quality of life gets better in a community, the problems of health will go from Apadarpana Vyadhi to Santarpana Vyadhi. Do you understand this? This is very important for us to understand. And as you see, India is a growing, we used to call India as a third world country, but it is not the same anymore. We are in a very developing phase, and many people are looking up to India. Many companies are trying to come and establish in India because we have a very good young growing workforce. And also, we are the deemed diabetic capital of the world. What I mean is, we are deemed to be we have the highest diabetic condition in this world. We have the highest blood pressure. A lot of lifestyle diseases are becoming more and more common because we are getting into Santarpana Vyadhis. Ancient times, when I say ancient, just few decades ago, poverty was a big problem in our country. When the British left, poverty was a big problem. When poverty is there, allopathic medicine is very important. But as the community progressed to lifestyle is getting better, the quality of life is getting better. Today we have more abundance problem. We don't have scarcity problems. Okay, just in your network, how many of you know if somebody died because there was no food? Today people are dying of heart attack. People are dying because there is an accident or cancer. It's all lifestyle, man-made disease problems that is coming, which is called, what we call it as non-communicable diseases. So he was telling, this is a problem that maybe within two or three decades, you will start seeing Ayurveda will become more and more relevant than any other time. So we are in a very cross junction of the future of Ayurveda, where more and more people are coming for this. So the reason why we started Aachaara, when we are trying to understand what is happening, we need skillful doctors. And you talk to all the organizations, they all say, on one hand you see that Ayurveda doctors will complain, I need to get a good job. I need to get more patients. But on the other hand, when you go to some of the patients, you see, I need to find a good doctor. You talk to organizations, they will say, I need quality doctors who are skillful in their ability to diagnose, skillful in their ability to identify and prescribe the right prescription. And what makes Ayurveda unique is our ability for holistic approach. Today, on the other hand, you will see Western people are repackaging the concept of pranayama as coherent breathing. Or Yoga Nidra is now repackaged as non-sleep deep rest. Same way, many of our functions like Dinacharya, it is called Circadian Rhythm Alignment Habit Protocol. This is a new protocol that some of the functional medicine doctors are using. I highly recommend you to read about functional medicine. And if you see what the functional medicine does, it is allopathic medicine integrating all the concepts of holistic approach what an Ayurvedic prescription doctor does. Like we ask about sleep, we ask about your Koshta analysis, we look at the prakriti of the patient, to what extent this is happening. We look at what are the genetic factors that are coming. The whole concept of Ayurvedic approach and holistic healing that has been taken and integrated, and that is called as functional medicine. I also appreciate why they call it functional medicine, because the rest of the medicine they call it is dysfunctional. And this is, now many allopathic doctors are also against this concept. They're saying it is not right. But this is the future, because we are realizing we are just not an individual. There is a multi-purpose approach. And what we can see, there is a lot of pain that cannot be just prescribed with a painkiller. There is a lot of pain people are having because of their posture, because of their stress, because of their eating disorders. Now there is this concept, wonderful concept in Ayurveda called Udavartam, because of which many people are suffering. And you cannot go to a pharmacy and buy a medicine and solve Udavartam. You have to change your lifestyle, you have to change your diet, you have to change your emotions, and along with that, our Ayurvedic medicines will support. And this is what good Ayurvedic Vaidya does. And as a part of transferring these knowledges, we all study a lot in BAMS or even if you do MD, but our real help comes when we go and sit with a practitioner. And we wanted to bring that in the online world, and now we are also doing offline events like this. Now, my colleague Dr. Aditya, he's doing all these events on the offline part. Now, our whole team from Sitaram, we are backing up so that more and more doctors are able to get the skills from senior doctors like Dr. Srivals. So today we have 2 events. Please take your effort to learn this, because every time when I look back in my practice, all the best ideas came when I went to a doctor, and it will be just 1 or 2 ideas. And these 1 or 2 ideas could be so life-changing in your practice. Some patient who's coming with pain, you will get 1 or 2 ideas. That is enough to change. And that one good patient is our biggest brand ambassador. They will give you more patients, they will send you more patients, and that trust is something that money cannot buy. That happiness that you get when a patient goes back, my pain is relieved, I'm feeling better. And in order for this, every Vaidya, it is to be in our DNA. I have to constantly learn. There is no other way. And the more you constantly learn, it just gets better. Sometimes, I agree, some seminars can be very boring. But our ability to go through that hard work of sitting and listening, maybe 2-3 ideas we will get. Maybe just by doing this technique, this problem can be resolved. That is a gold mine. And in order for that, we have to go through this process of attending these seminars. We have to be a seminar junkie. That's the way we can learn better. Seminar, or go and sit with a doctor or learn to understand from this. So today we have in the morning session, we have Dr. Srivals. In the evening, we have Dr. Kannan. He's an allopathic doctor and an Ayurvedic doctor who studied orthopedic medicine. So it will be very helpful. And we are also telecasting this on our Aachaara Rasaayanam platform. How many of you attended Aachaara Rasaayanam online? Just to understand. Please do understand, this is an online, every Sunday we are doing a webinar. A good subject matter expert on certain diseases, they come and share their clinical expertise. Please attend this, and the recording is also sent, and we are sending you the details about this so that our own whole Ayurvedic community can uplift together. So thank you all for coming, and Srival sir, we look forward for your presentation. And Dr. Sridevi, so we have a small product launch. So one is deep sleep, as you would have seen, and another one is fresh start. Now, as we all know, in Trayopastamba, Nidra is one of the most important part of our condition. So this is a small contribution. We have combined few herbs, and we have seen fantastic results in how it is improving the REM sleep and the deep sleep of every patient. So, and it is not habit forming. So we would like to have Dr. Aditya to come and have a discussion.
Thank you, sir, for sharing your knowledge. We have now arrived at one of the most awaited moments of today's event, the official launch of new clinically validated Ayurvedic formulation by Sitaram Ayurveda. This launch marks not just the unveiling of product, but the accumulation of extensive research, traditional wisdom, and the modern science. At Sitaram, every formulation is crafted with the precision rooted in classic texts, yet tailored to address today's clinical realities. I'm inviting Dr. Vignesh Devaraj sir for official launch. For explaining details of newly launched product, I am inviting Dr. Aditya Pidambara Panikar, AGM, Marketing and Innovation, Sitaram Ayurveda. Over to you, sir.
Good morning, all. So these are our newly launched product. I just mentioned about this product. The first one is deep sleep. So deep sleep is targeted for the sleep disturbance and for daily use. So the importance of quality of sleep. So as per the study, poor sleep affect over 70% of the adult today. So 33% experience sleep disturbance regularly, and sleep issue can lead to health complications. So 25% report a daytime fatigue often. So because of the lack of proper sleep. Next. So deep sleep capsule combines nature's finest ingredient to promote sleeps and soothing effect. Its main ingredients are valerian, chamomile, lavender, and magnesium. So the benefits of valerian. The valerian is known for its calming properties, often used to promote a restful sleep and reduce anxiety. So it's a natural compound and can help to improve sleep quality and duration, make it proper. So valerian is also used in Ayurvedic drugs. So this chamomile is not used in Ayurveda. So this is actually a food supplement, this deep sleep supplement. So chamomile is known for its calming properties and promoting relaxation and improving sleep quality. So its natural compounds can alleviate anxiety and help to create a peaceful atmosphere. So in Western world, they are using chamomile tea for inducing sleep. So the lavender is also not an Ayurvedic text reference thing. This is also from the food supplement. So the lavender is known for its calming effect on the mind and body. It promotes relaxation, reduce anxiety, and improve sleep quality, making it essential. So dosage is just only one capsule is needed. As per our study, just one capsule is needed for a good sound sleep. There is no side effect reported. So we have studied through an insomnia severity index scale. So before and after, though ISI measures the sleep's difficulties and their impact on daily life. So a lower ISI score indicate improved sleep quality and overall well-being. Effective treatments can significantly reduce the ISI score. So regular assessment help to track the progress and delays of intervention. So the understanding ISI score, the insomnia severity index score is a crucial tool for assessing the sleep disturbance. Comparative data from patients showing significant improvement after using deep sleeps, highlighting the effectiveness of their treatment. Monitoring ISI scores helps to identify the trends in the sleep quality and impact of interventions on patients' well-being. So there was an improved ISI score after the induce of deep sleep capsule. Next. So the overall study is like that. This ISI scores illustrate a significant improvement of patient sleep quality after the usage of deep sleep. So particularly the name of patient number 5's ISI score before deep sleep was 16 and it is reduced to 3. In case of patient 6, it was 9 and it is reduced to 1. And in patient 2, a significant drop in their ISI scores from 23 to 15. So these actually we have done this study in from foreign nationals and also the Indians. So different continental nations have been done in this study. So this was the improvement we obtained from this. The bar chart illustrated a significant reduction in insomnia severity among the patients. Next. So that's all for the deep sleep. Next. Okay, the next one is a Fresh Start tablet. It's an Ayurvedic solution for natural digestive health. Next one. So the constipation affect over 20% of the global population. So many seek natural remedies and alternatives from harsh chemicals. So Ayurveda offers a holistic approach. There are so many Ayurvedic laxatives like Avipatti Churnam and there are different ones. The main difference from that is that if you are providing Avipatti Churnam, we have to give it to at least 15 gram. So the patient is not willing to take that much quantity. So we have to find out a dosage form which will be adequate to deliver the optimum result. Next one. So the key ingredients of Restart is senna leaves and haridiki. Apart from that, this Eshti Madhu is also there in this combination. This herbal formulation aids in relieving constipation and improving digesting comfort and supporting overall well-being without any adverse effect. The emphasizing natural ingredient Fresh Start tablets in Ayurvedic principle lead to sustainable result. Next. So how Fresh Start works? The Fresh Start tablets utilize a blend tested of Ayurvedic. Actually, it works based on the senna leaves. So senna leaves contain senesoid. It's a senesoid A will be act only on megacolon. So if you take the senesoid tablet in the night, it will take 8 hours to reach the megacolon. So it is a free, safe laxative. So if somebody is taking this Fresh Start, he will only start to defecate in the morning. So that is why we developed this product. Next. The study, we have also done a clinical study on Fresh Start. So the study was done among the patients from the age group of 18 to 65 having constipation and how this will be used. A double-blind placebo-controlled trial design was utilized, allowing unbiased comparison of Fresh Start. And data was collected regularly with our monitoring. Next. So it was collected based on their how strainfully they are defecating and what is their gastric disturbance. These were the scales we used in that. This pie charts or the improvement in different patients categories. Next one. So the usage report improved bowel regularity within just a few days. After 3 to 5 days of usage of Fresh Start tablets, they reported that they have an improved bowel regularity. And many appreciate that natural ingredient feeling safer and healthier, because we have also done this study with the foreign and Indian origin patients. So they have said that it's safe and healthier. Testimonials from these foreign nationals highlight that the bowel movements compared to other solutions were much better. The customers love the gentle nature. How to access these tablets? So now we are providing to our websites and to our direct sales. Thank you. And keep following our social media, Instagram pages also, because we are not only providing ad in that, we are providing healthcare solutions and how different tips. For example, our director, Dr. Vignesh sir, has been done an interview with Thomas Tuchel. He's a famous English football coach. So you can access to this type of knowledge, how the foreign nationals perceive Ayurveda. This will give a different perspective on the growing Ayurvedic generation. Thank you. And I would also like to thank our managing director, Dr. Ramanathan sir. Sir was not available today, so he was not able to come here. And he's the vision behind this clinically proven Ayurvedic solutions from Sitaram Ayurveda. Thank you.
It's given me immense pleasure to welcome you all to Rasaayanam, a continuing CME hosted by Sitaram Ayurveda, a name deeply rooted in classical wisdom and committed scientific innovation. I'm inviting Dr. Anujoy, Research Officer, Sitaram Ayurveda, for moderating the session. Over to you, Doctor.
Good morning, all. Welcome to, now we are moving on to the first session of 241st episode of Aachaara Rasaayanam, with the topic Comprehensive Management of Low Backache, Sciatica and Cervical Spondylosis, the practical insight into Marma therapy. And before moving into the session, a few words about Dr. Srivatsar. Dr. Srivatsar is a distinguished Ayurvedic physician and Marma specialist from Kerala with over 3 decades of experience. He completed his graduation from P.S. Warrior Ayurveda College, Kottakkal in 1989 and post-graduation in Shalyatantra from Government Ayurveda College, Trivandrum in 1993. Renowned for his expertise in treating bone and joint disorders, Dr. Srivatsar has successfully treated complex cases of IVDP and spondylosis that were otherwise indicated for surgery. He has served in prestigious positions including Principal of Ayurveda College and Hospital, Coimbatore, and Principal of Rajiv Gandhi Ayurveda Medical College, Mahi. A pioneer in Marma therapy, he has developed innovative treatment protocols and formulated over 20 new medicinal combinations. He is currently working as a guru in Asti and Marma Chikitsa under the Rashtriya Ayurveda Vidyapith and serves as honorary director at Swasthya Kshetram Ayurvedic Health Center, Nallepilli. Dr. Srivatsar is a recipient of multiple prestigious awards, including the Bishop Pratibha Award and Agnivesha Vaidyaratna Award, recognizing his exceptional contributions to Ayurvedic medicine. Welcome, sir. Welcome to the session.
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्योर्मा अमृतं गमय ॐ शान्ति शान्ति शान्तिः ॐ सहना भवतु सहनौ भुनक्तु सह वीर्यं करवावहै तेजस्विनावधीतमस्तु मा विद्विषावहै ॐ शान्ति शान्ति शान्तिः गुरुभ्यो नमः. At the outset, let me thank the Sitaram Ayurvedic for organizing such a wonderful occasion. You are all welcome to the 241st episode of Aachaara Rasaayanam. And as it is told that when you follow Aachaara Rasaayanam, no other Rasaayanas are needed. I believe that it's our responsibility, or it's our duty, or it's our pleasure to give a big hand to Dr. Vignesh and Dr. Ramanathan for having started a program like that. I wish that we have to give a very big applause for this one. Because what the effort it takes to organize such a function, coordinate such a function, it is a very arduous thing, which many of us as students or junior doctors will not be knowing. And I am also very glad that Tripunithara is witnessing two great events in this Saturday and Sunday. Yesterday was the inauguration of the Sports Ayurveda course, MSc course in the SFRS, School for Fundamental Research under the KUHS. And also today we have this Aachaara Rasaayanam on particular conditions which we generally face in this in our practice. So I also bring the blessings of Purnatrayisha. Today only to tell the fact, I was having a belief that Purnatrayisha was Shiva. But when I went there only I could understand that it is a Narayana temple. So we know that as far as Ayurveda is concerned, why I am telling this, because you see that rooted in tradition, backed by science. That should be our approach. That should be our way of understanding this. Otherwise, we are no different from copycats. If we understand the tradition only, then we will be able to tell something beyond what is generally told. And this is very true with Marma Chikitsa also, or our Ayurvedic approach of treatment also. So before beginning the class, I think that now I'll have to make it into a 1.5 hour session. And later this Aachaara Rasaayanam, one more mode should come, is what I wanted to tell to Dr. Vignesh and all. Among that, whoever is very, 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 now we have come to that only. Hands-on learning for 10 selected people. Some of the organization is doing that now. And that works wonders. And so this is a exposure to how we have to think. And that thinking makes a lot of differences. This is a pan-Indian audience is there, I know. That's why I will have to keep it in English. And you know that where we miss the bus is where we are strong, we are just leaving that. Whenever we want to talk about these diseases, we talk the modern part of it, and then we talk about the Ayurvedic treatment for it, and we don't link it. Why it is not being possible is because we are not rooted in the tradition. We are just want the medicines from the tradition, but the thinking of how it is, because it is absolutely told as Hetu Linga Aushadha Jnana. Chikitsa has to be like that. And the biggest thing we tell that we already study that our sciences are in sutra form. But we don't know what is a sutra, and we don't want to know the expanse of that sutra. So what happens is that, local this one, Marma slogangal parayunnundu Marma vibhagathil, that we are telling a little number of slokas in the Marma vibhaga, and nothing else is told. How it is practiced, how it has to be done, or what is the way in which you are using it is not told. Now the same thing, why we are not asking about Abhyanga Majaret Nityam only is told how Abhyanga has to be performed, what are all the different methods of Abhyanga, everything, is it there in the Ashtanga Hridaya or anywhere? Situations have been told in different chikitsas where we can apply these things. From that we have to gather. Why it is effective? It is Drishti Prasadam. When it is told that, okay, when you apply it on the Shirashravana Padeshu, when it is applied in the Pada, now you know the connection, because in the Uttarasthana it is told that how much care you take for your feet will determine what you will have this thing on your eyes. So we have to connect this. But what is happening mostly is that we are taking Shushruda's own words and what is that? Ekam Shastram Madhyanana Vidya Shastra Nishayam Tasmad Bahushruta. Is it not? We have been telling, and then we directly go to the modern context only. We have enough of Shastras here, we have enough of practices here which we have to go. Dr. Vignesh, I tell that first, before researching, I think we have to search. What is there within us, we have to search, and then we have to go beyond that is what. So how these things are linked. So only today, I have, rather in many of the stages, thanks to my gurus, whatever right thing I am telling is the blessings of my gurus, Dr. G.S. Raju, Dr. Jayachandran, who has taught me the Nadi Marma Abhyanga, Dr. Mohanlal, Dr. Chandrasekhar, all the other scholars who had been there teaching, or from whom I was learning Marma Chikitsa, along with Ayurveda. And if we consider Marma Chikitsa is something different from Ayurveda, there we lost. Even whatever it is, Kalari Marma Chikitsa or Tamil Marma Chikitsa, whatever it is, we have that, we all are dealing with the prana only, and it is what you call done in a prani only. Without prana there is no marma, you have dhatus, doshas only, or the other things only. So basically we have to understand these things. So in the finishing school I tell Dr. Vignesh that what we have to know is what we don't learn from the normal schools. Because last I tell that to whomever who is coming to learn from me, I tell that, okay, I was from a tutor to a professor and a director in the college. But in the college, there is a routine thing which has to happen. What is that now? Is, you know that syllabus, whether it is covered. So the syllabus is covered actually, and after during the internship, after that, when you start practicing, we start uncovering the syllabus where we have to learn. There only Aachaara Rasaayanam comes in that. What makes you uncover it is situations, seminars, workshops like this. So that is the relevance of it, and when 250 is a big number, you know. So 241st is what we are. I wish and pray that Sitaram is able to make it a perpetual thing when which goes on every week or every fortnight at least, in that way. So this is very much relevant, and I think very few occasions happen for Aachaara Rasaayanam on a platform, because last 2 times I believe that I was in front of my computer only and was imagining that somebody is listening to it and then doing that. Now we have on the offline mode. And there are limitations, because I cannot go into like a class, it has to be a presentation, I know that very well. And so whatever it is, because the next session is in the afternoon only, and I believe that Dr. Aditya has not given you the samples now of deep sleeps and all. The other one, I think it has to be daily fresher, what do you call? Fresh first has to be the thing. So we will all be fresh, and we will see how we can understand our own Shastra better and our own approach. I am telling this because when we interact, for us the modern science is a big thing. Dr. Vignesh opened out that topic when he told that happenings in Mahabalipuram. Now when we want to learn something, even some of the points in Marma I learned from scholars who are outside, who came to learn from here, stayed in Kalaris, and then they learnt, and then the same thing I learnt out, like it is not from our own source, like sometimes. This should change. We are talking about Bharatiya Shastra, we are talking about our own Shastra, then if we are importing ideas from outside only, that's not a ideal thing. Like. So in every stage now it has happened that we have to have our own tools. So before starting this class, I tell that a new tool has been invented. Whoever has listened to me, it will be that many things will be a repetition. But I tell that now I think that whoever has gathered here, every class where I go, I tell that who has gathered here, from this moment, that is 11:15, is it? On this day, 29th of this thing, you are going to start, you are using anyway stethoscope, you are using many other scopes. Is it not? Is it not? Is it not? Wow, this is the biggest disadvantage with our crowd, I believe, that responsiveness. You have to be responsive. Otherwise, it will be a monologue. So now, from this moment, you are going to use Marma scope. You consider that you have the Marma scope taught to you in the second year or the first year when you learn the Anga Vibhagam Sharira, which include that does not stop with Shariram, it includes many other things in that chapter. And because Nidhanam is there, there is the Chikitsa there, how far you can do the Chikitsa, it is there. So many information is there that you are going to brush up, because some of the instruments we will keep up, which we are not using. So we are going to take it out and then we are going to use it. So what is a scope for? A scope can be, yantra can be for, being a Shalya person, I tell that can be for darshana, it can be for doing any kriya, it can be for another thing also, to protect the other areas which are being dealt with. So Marma Shastra also has all these factors. Okay, so let us open the Marma scope. Okay, yeah. We will start in between. I will ask whenever you are feeling this thing, the subject comes, I will introduce one video also. These technical people will help me. And so that I am going to give you only one thing, that many a times when you take something as a different thing and when you want to assimilate it, it's a very difficult thing. But when you know that you are improvising on something what you are having, it is much more easier. For example, is Abhyanga the basic thing in Ayurvedic treatment modalities? Is it? Other than the physical treatments I am telling, because again in the afternoon you are going to talk about physical treatments only. Is it not? In Malayalam we tell that at least at least you should not apply a little oil. That is the first thing. And this we have what you call neglected, is what I am telling. The scope and this thing of how we can apply the oil, which oil you can apply, okay, leave out the oil, what is the pressure, what is the rate, in what condition you are going to apply, why we are applying like that. I will be telling about the different methods of the massages which you are doing, and how the knowledge of Marma makes it a Marma massage or a Nadi Marma massage. Now we have a situation where we will be very happy to tell that which are the cranial nerves, if I ask. Everyone is ready to tell that, okay, 12 pairs of cranial nerves, this is thing. But how many nadis are there when we ask? Sir, in Yoga Shastra, some Sushumna nadi, some Ida nadi, Pingala nadi, it is being told, that's all. But we tell that, okay, in local medicine, if you have a headache, right side headache, if you crush a piece of onion or shunti and tie it on the left toe, then it works. So we know that, but we are not able to explain it. One more question I ask you is that how many of us have asked that during the process of Abhyanga, why we are putting the oil on the head first? Put your hand here and then tell, sir, I have asked with my teacher. It is just this thing, no, it is done like that, so we also do like that. Whether any SOP has been told by Acharyas, you start with, of course, Shira, Shravana, Shira, it has been told, that is an indication, we can tell that. But why? Have you asked that? So we know that once we know that, when you open the Marma scope and find that, okay, this is the Marma, there is a Marma on the top of your head, And that is called, each and every marma is named according to what it does, or some, that there is a meaning behind it. So when you tell that, when you understand that, okay, it is called Adhipati and it is a master, and so you have the master switch on your body, and that is where the master Adangal can be done, or the Vata Shamana can be done. There we understand that, okay, because of that we are doing it. So that's what I told, that because you need not wonder what is Marma scope, it is understanding what is Marma Vijnana. And that will start opening up things for you, and in that way we will have to today analyze on the conditions which has been given, like the low backache, the sciatica, and the cervical spondylosis, etc. So I am not going to give you again a overview of the modern anatomy and other things. Every seminar is having that. So we will start talking in our own words. Then only we will be able to understand, is there, my dear doctors, a difference between the words Snayu and Kandara? We immediately go for Bhasha Institute translation only. Tendons are, sir, muscle attachments, ligaments are this one, etc. We don't go to the Anga Vibhaga chapter where we tell that, okay, Snayus are 4 types, among that one is Kandara. Otherwise, we will tell that Vagbada was wrong. What we will do? Now that Gridrasi is given as an example of Snayugata Vata, and when Gridrasi is being expressed, Ya Kandaraha, which is the Kandara, which is that, there it is told as Kandara. So we will tell that Aachaara is confused, sir, whether he is telling about the ligaments there and he is telling about the tendons here. That will be our answer. So let us come to this thing of context. Let us learn our own language. Let us express in our own language, because we are not to satisfy anybody before we satisfy ourselves. So many times we, as especially students who have come out, will feel that, okay, now in this world we have to talk that language. We know that that's a very common thing. Now when you have something uncommon, only it is being accepted, and that should be in tied with what is happening now also. Okay, then I will get into the topic. Can I have the... Hello? Yeah. So, today's topic is comprehensive management of low backache and sciatica and cervical spondylosis, practical insights into Marma therapy. So, Marma therapy as it is, we know that, now I have opened the Marma scope, so now it will start occurring for you. It's only like thing like that. Actually, Vignesh sir, I asked whether Marma has to be taught. Many times when we are able to listen to our body and its responses to any stimulus, then we know that we need not be taught about that. For example, when we have headache, what we commonly do? What we do usually, commonly? No balm and all, nothing is there. Then what you do? Generally what you do? This because today there is no time, I am not making you do. But usually what we do when we have a headache? You just do like that. Anyone, generally, if somebody having Ottachani, that is one this thing they will be. But what made you do that? What made you do that? Or after my 2 hours lecture, then when you are getting up, your hands will go here and then you will straighten up yourself. Or after the 3 hours exam and all you have seen, no? You put this thing and then do like this. So what makes you do that? That's where we have to shift our vision, shift our way of thinking, and then we know that there was some vata disturbance over there. Something, our thinking made us have headache. There is more of vata disturbance over the head. We have to do some block to it. This was not taught by any teacher, any anatomy teacher, any pathology teacher, or even right from school. Why it happens? Because our body knows that whenever there is a harm for the prana, whenever there is a deficiency of prana, you have to increase it. Whenever there is an overflow of prana, you have to block it. Swabhava Vata is Chalatum. If it is Adichala, you will have to block it. Stambhanam has to be done. If it is what you call Stabda, you will have to stimulate it. Nothing more than that, there is no magic. Whatever you do with your hands, with your fingers, to do this on the body of the patient, that results in Marma therapy or Marma massage. When you know that which Vata is affected, which Nadi is affected, which reflects in the lakshanas of that Marma, then you will be able to do that. Okay, this is why. So now you know that I don't have much to talk. If you start thinking. Because in this condition also, how a pain occurs when there is a disturbance of Vata. What is the relationship between Marma? Marma basically it is where there is more of pain, those points are called, or those areas are called Marmas, is it not? So we'll come to understand from our own view how this can be done. Can I have a slide changer or? Okay, next please. Okay, overview, introduction of these topics, understanding the spine, insight into Ayurvedic aspects. So now don't expect too much of the structure of the cervical spine is this one, etc., which all we have studied. And we, as I told, no, we know very well how many great cervical nerves are there, everything we know that. Understanding strategic approach to treatments, selection of treatment modalities. This is where it is very important. Strategic approach to treatments. There are many treatments. What I will do for that patient? Every cervical patient, every spondylitic patient, every low back patient is having the same disease. What is the difference in Ayurveda? It's also true to modern also when it comes to strategizing the treatment. But we give more importance not for the disease but for the patient, is it not? That's what we do. So here that is very important. So many a times we are confused that whether to do Abhyanga there or whether to do Lepa there, whether to do a Dhara there, etc., etc. I gave an indication here where to do this Bandhana, which will be shown in the afternoon, they told. So Bandhanam is where, now you got it, no? Whenever Vata is Adichala, whenever Chalatam increases the pain, you will have to do Bandhana. This is the basis of it. Like, so discussion on various novel approaches. Now, whenever we have a backing of, okay, in Swedish massage, there is these techniques are there, then we are very happy, no? We have that. And it is very scientific. But otherwise, we believe that something has been told by Acharya, something is done by these Marma Vaidyas, etc., etc. It is not credible. But when we get an insight from the modern this one, okay, now I am pulling when doing a back massage, I am lifting the patient here, giving a traction. Then, okay, if I tell that that's some Syriac approach, it's wonderful. It's a Maitland's method. So it is a physiotherapeutic area. I have not gone too much into it, but I would like you to understand that there had been parallel things in modern medicine also, which we are having, but we have stopped using it because as Abhyanga we are doing only stroking. So I want to understand that there are many types of treatments which are there. Application of Marma massage in low backache, sciatica and cervical spondylosis, various methods in the roundup. Next please. Okay, so we will have to understand the clinical presentations, pathology behind them. For everything there is no time, so you can whatever you have studied, you have imagined. Treatment modalities available. Classification of patient is very important. Again, I told that we are not generally treating the disease, but we are treating the patient. Severity, you can see that some people now also, every day I get at least 4 or 5 IVDP MRIs. Sir, we are from so and so place. This is our MRI. Have you got a treatment? Until that, in Tamil there is a telling that Nijattai namba, niyalai nambade. That is, you don't believe the shadow, but believe this one, the right thing. So I tell that if anything is possible, I will go through that. I'll give suggestion, but if any possibility is there, please come before me. Because then only I can assess what treatment can be done, what will be the best for you. Because it may be in the MRI, it may be grade 4, it may be grade 3, whatever it is, it may be a different areas of IVDP, which you know that, but patient will be. Sometimes it happens, no? How many, all are practicing, no? All are practitioners, no? Some of you are students. Practitioners, how many of them? Many a times we know that they will show the MRI and then we will tell that, oh, patient has not come, no. Then they will tell that, no, patient is outside waiting, can I bring him in? Some other will come with the MRI and tell that, okay, why the patient has not come? They will tell that patient is not able to move from the bed at all. That's why I bought the report. So how far we can believe on that? And conditions apply, you would have written every MRI report under that. This is only an image. Please correlate with the clinical conditions before deciding the treatment. That's why I told that classification of treatment, what approach, or whether you have to do just little abhyanga for him or whether you will have to do a chauti thirumal, as we tell, a hard massage on him, all determined by classifying the patient, selection of treatment procedure and application and evaluation. Wherever you are doing something, please evaluate. We have intervened with some medicines, we have intervened with some methodology of treatment, then you will have to evaluate what is the outcome of it. If you don't do that, then you will be doing, you are not a Shastriya Vaidya. Whatever result you get, like Aachaara tells, it is Edricha. So that's why I am telling that everyone has to be not just a copycat, but a thinker also, that they can apply it properly. Next please. So clinical presentations, how do we get the patients of this neck, back and spine, neck and spine we can tell. Now I'll combine with this three things into spine itself, the cervical conditions, the dorsal conditions and the low back or lumbar conditions, so that it is easy. Now we can see that usually we write, no? Whenever the patient comes with either catch in the neck or catch in the back, now it's season. All Vaidyas will know that now. Season has come. There is no reason. Morning I got up, I was not able, I got a catch. This is the season now. Vata predominance coming due to the Ritu, etc. So here I can say that just to get the language, just to get to open up your scope, I am telling that Griva Prishta Kadi Graha, that is neck, back, low back catch like. Griva Prishta Kadi Ruja, neck, back, low back ek. Gridrasi sciatica. Khalli, there is one definition, no? Gridrasi Tivra Ruja, it is called Khalli. So you know that Khalli is there for Vishwaji also. And then Bahu Shula, Apparamek, Urashula, Sakti Shula, etc. Now once you go through that, now if you have opened your Marma scope, you will know that, sir, Bahu Ruja comes in, Bahu Swapa comes in, Amsa Falava Marma Bigada, which we have learned. So that's what I am telling you. When we are learning Anga Vibhaga in Marma Vibhaga, we are not just taught the location of the Marmas, but the effect of it also, the consequences of it also. If it is a Snayu Marma, what are all the Lakshanas it may show, that is also told there. Only thing is that we have to revisit that. Whichever we have not, whichever we have forgotten, we have to revisit it. Okay, so Urashula, why I told Urashula also? You have practically some patients coming with, sir, pain, I went to the night it was paining, I went to the emergency, they took a ECG and they confirmed that there is nothing, they took troponin also, it is also normal. What will be the, are you suffering from neck pain? Yeah, since many days I am suffering from, and that comes to the pectoralis. When it comes on the right, you are not so much bothered. When it comes on the left, you are bothered. So you know that that is also there. Sakti Shula or the pain. First symptom which I tell you, my dear doctors, whenever a patient comes with pain in the calf muscle since last many days, when I am walking it is increasing. Anything like that, don't stop with some application of oil on the calf muscle only. When you know Marma Shastra, when you know Shastra properly, then you know that the origin of the pain is not there but at the Kati region. So I tell that, sir, they asked whether we have to put oil there only. They tell that no, you put the oil here, because here if it is corrected, there it will be naturally corrected, because that's a referred pain from this one. So understanding the modern concepts also is good, which opens out our own concepts. There only we realize that how many trikas we have? two trikas, one here and one here. What is the importance of that trikas? Those are the energy regions which connect the axial skeleton to the appendicular skeleton. So if you deal with, how many of you have done Tamil Varma Shastra? Shanmugam sir? Varmam? Yeah, you know that there is a Mudichu here, there is a Mudichu. And that, you know that is the place where modern physiology or kinesiology, when we will talk about that, it will tell that, okay, there the forces balance. There the, energy is balance to make you stand erect or whether to stand like this or stand like this, etc. So once you open the Marma scope, I am very, very sure that once a patient is coming inside, you will tell that, sir, his Kadikadaranam is weak. Sir, his, Janu is weak. Only thing is that you have to open it out. You have to understand that. Okay, so that's why these are the lakshanas which are coming or representing these conditions. Next, please. So now clinical presentation as we study as Vyadis. My dear doctors, it is now Ashtangradya, Vata Vyadi, 19 diseases or some number is only told. No, it's all Suchana only. Whereas it is told that when Vata is in Snayu, when Vata is in Sira, and Vata is in Twak, Vata is in Rakta, Vata is in Mamsa, what all Lakshanas will come. So many diseases have come in ICD now. And that's why I told that if you go like that, there is no limit for it. So that's why Acharya has given a tool like you understand from the dosha point of view and the dhatu point of view, whether you call it, whichever name you call. Now how the diseases are named, do you know? Do you know that why we don't have Raman method of manipulation, Krishnan method of manipulation, etc.? So what they tell that we don't document. If you go to any Marma person, any Vaidya madam or any big, go to seniors, they tell that what we are interested, is it not, doctor, that patient should get benefited, that's all. Shastra is there, we are using it. To whom we have to. But nowadays what is that? Document it. So that's why now I think that the Marma scope can be patented. And it should be a free patent that every Vaidya should use it. Okay. So we have to understand that. Now, whatever be that, what is available in the textbooks and what we write as diagnosis mostly are Apabahuga, Vishwachi. Now, Apabahuga is learned at Amsamolasthido Vayuhu, is it not? Have you thought about that? For us, what is Amsa? Usually Amsa Sandhi only it will. Whether the Amsa Marma is in the Amsa Sandhi? Whether the Amsa Marma is in the Amsa Sandhi? Which is the Sthana? You know that Griva Bahuyor Madhye Skandasya Ubari. So how we are learning? With a belief that it is Amsa Moolam is inside the axilla. Only no. The appendage is attaching over here. Here only the transactions occur. Now every one of you see that you will have a tender point. It's so easy. Amsa Marma, when you put your hand here, and if you give a press there, it will be painful. And so that's why whenever we are having neck pain and all, we will go there and then give a massage. At the end of the day, now before taking sleep, is this one, if you give a good massage over here and then take it will be much more beneficial. So that happens when you know the Marmas, no? Okay. Then Manya Ruja you would have diagnosed, Manya Stamba you would have diagnosed, torticollis-like conditions, Griva Stamba like, patient coming like this, children having sternocleidomastoid, this one coming like this, etc. Okay. Then Bahu Hasta Supti, Bahu Hasta Daha, that's what I told. Amsa and Amsa Falaga, if you see that, many of the cervical, this I am telling because I am not talking much about this one, I will tell that cervical conditions, they come to the clinic like this. Then we investigate and find that there is something in the cervical region. Patient presentation is that, sir, I am not able to hold my hand like this. Only if I will keep like this, if I keep like this only, I am able to sleep. Where is the problem? You know that. So this we have to diagnose. So that's why when you have the Marma scope, when a patient comes from telling that Nowadays I am feeling weak in my hand, I am not able to lift it properly, I am not able to take something, then you have to, then as if you are using the marmoscope, you will tell that, you will ask whether some 2 or 3 months you had a hit here. Did you fall down here stretching that area? That question will come. The Abhigada, Janya Marma Abhigada, this thing will be coming over there. Otherwise, if it is Nija also, the same pressure effect is getting there. And we usually, as in the leg I told, we usually do treatment for that part only. And I am very, very concerned about one thing also, that Panchakarma is improving, but reductionism is coming there also, I think. We all have actually holistic reductionism. So that's why now we have a knee problem. Especially, I am not blaming, but in North India, I find that the Janu Basti is done. If it is this localized, everywhere localized, this one has been done. Whereas in the Kerala method, if you see that Tadavi Kattuga will be local, but the other thing will be treatment, reconditioning will be whole body. Patient is having back pain, neck pain, but we 2 or 3 days local thing will be done. Tell that better you go for a full body massage. Because every other, any imbalance in any part of the body is going to affect this one. A long-term patient having long-term backache will surely after 6 months will come with a attitude. This one, if you can see that the patient will be, is one of the shoulder will be high, other one will be low. Can evaluate immediately till you can see that. That's what I told that. Use the marmoscope. You will find that the patient will be coming. When you see itself, you can tell that, okay, there is something over there. Okay. Sakti Padadaha. Kubjada, Kanjada, Pangutva, Kunitva. What is the first three? Many people know. What is Kunitva? What is Kunitva? Kuniganjata. So now that's what I told, that when we have studied Marma properly, we know that, okay, in Manibandha, Marma Chada or a Roga there, any Vyadi there, Vadarakta there, in the Kurpara or in the Kachadrik, there will be Kunitva, is the deformity which will be this thing. So that deformity may be due to structural change, it may be due to some functional, this one also, contractures, it can be, etc., etc. So start thinking from that way. Next please. Next please. So Nidana causes Nidana of Vata Vyadi, all Vata Vyadi Nidanas you'll have to consider for this low backache, cervical spine and dorsal spine conditions. Nidana of Bhagna and Sadhyavrana, that includes the traumatic incidences, etc. It can be classified as Bahya and Abhyantara also. You know that when Dosha Dushti happens inside, it is Nija, and then when it is due to external factor, this is Agantu, and Nija Agantu, Bahya, Abhyantara, etc. Now, I'm just recollecting, making you recollect. And whenever we are imagining the Prashtavamsa, I already told about the functional, this one of it. When you remember the Prashtavamsa, what all from our point of view we will have to remember. I'm not just trying to translate that, sir, you are again telling that the bone is there, the cartilage is there, the ligaments are there, the supporting muscles are there. Okay, that's only, but whether it has been mentioned over there in our Shastra, when we know that it is mentioned over there in our Shastra, we become more authentic. We are talking about not we are importing something from outside, but it is there in the Shastra itself, and that's what we are doing, we will be telling. So what are the structures there? Asti and Kasheru, Taruna Asti, Kasheru Asti. That's the spine, the components are called Kasherus, is it not? Sandhi, which is Chala and Rachala. Why I have put question Chala and Rachala? Take the total backbone into vertebral column into consideration. Whether it is Chala or Rachala. Why we have more of the cases in the C7 D1 area and the L5 S1 area? I just told 2 trikas. You know that comparatively that is the more mobile cervical vertebra joining the fixed dorsal vertebra, which is not fixed but having limited movement. Again you get a place where you have the mobile area joining the immobile area. Its transition is there from the dorsal to the lumbar, and the lumbar body is made for structural stability and not mobility. So that's why we have a more mobile cervical spine and this one. So that is very important. And then the kandaras and snayus which are there. This also, why I am telling, because I told that every neck pain patient is not having cervical spondylosis. It is just that he is having a WhatsApp neck, is it not? And now it has come that late night YouTube neck also. Like because you lie down and then see a movie keeping this thing like that. So then because the advertisement comes that a gadget is there which you can fix to the cot, that will hold for you, and then you can lie down like that. So many innovations are coming now like that. Because when you start seeing a movie, we will see some doctors who are seniors, they may not be, you observe your children, mostly they will be doing that. Over 20 minutes, 15 minutes, we will see. Then it goes on, goes on, goes on. Is it not? You start at 10 o'clock and at 12:30 you find that, okay, finished. Until that time, you are not winking your this thing, your neck is held like that, and what is happening, you know. So there need not be every time an accident to occur, a vertebral fracture to occur, and then the pain come. It can be due to the kandara and the mamsa there. Mamsa Beshi Kandra Snayu. Griva Prishta Kadi Triga Shroni Pradesha. So the Pradesha, where the Vyadi is occurring, that we can subject to that. Next, please. Srotas is involved now. Dushti of Mamsava Srotas, Medova Srotas, Astiva Srotas, and Majava Srotas. Do we think about that? A patient is coming with pain in the back. Maybe we think that, okay, this lumbar muscles have gone for this one. But where you get the treatment from? If you don't know the dhatu which is involved, can you design? No. It may be a simple lumbago. Now I am very critical in that because many hospitals don't diagnose a simple lumbago and a severe IVDP. So that hospital has a protocol. If you have back pain, you go to the hospital, 4 weeks treatment. First week Abhyanga, second week Podikidi, third week Elakidi, fourth week Pirichil, and if it is possible, fifth week, one Yogavasti also. But if you have found that it is just a lumbago, maybe 5 days lepa with some hot water fermentation and some anulomana chikitsa, virechana will be enough. This is where we fail if we don't understand the pathology behind it. So every time don't think that something bad has happened to the spinal cord or the vertebral column. It may be associated with the muscles and other ligaments which are associated with the vertebral column only. Next please. So deeper it goes, no? When it goes to Majjava Srotas, then you know that it is a spinal issue also. It's not a vertebral column issue. When it is Asti, it is a vertebral column issue. But when it is a Mamsa Medova Srotas, then you know that it is with the whatever ligaments which you are talking, anterior ligament, posterior ligament, the paraspinal muscles, the supporting other muscles, and the intercostal muscles which are coming and joining the interspinous spaces. So many things. Next. Okay. Now to think over Vada and Kaba are involved. How flexibility and stability are the opposite attributes which coexist in the backbone. In the backbone, both of this exist, is it not? It's a difficult thing. Practitioners, you know that they will ask, the patient will ask, sir, what you are going to do after the treatment, what I will. We tell that your backbone will become strong. If something becomes strong, whether it will be flexible? That will be the next question from that, no? Then if it is becoming strong, whether it will become flexible? No, that's why we always tell about the example of the bamboo or the reed or the grass. It can, if it is a rigid one, strong one, a big blow of wind can break it. But if it is flexible, it can bend. This is the nature of our backbone. This we have to understand. So we are contributing by Snigdha Ushna and whatever Chikitsa method which we are following, the strength as well as the flexibility over there. I try to explain these things, and then my dear doctors, I had been for a physiotherapy, this one also, then they told that, sir, if your science is telling all these things, there is nothing new in our science. They were just telling that if you are doing all these things and understanding the principles behind it, then kinesiology is far behind. But what we do, we don't try to understand this, but try to understand from the modern aspect only. Modern aspect, advanced modern aspect we should see. Nothing wrong. We believe that it is, we don't study the body in a functional way. In a structural cadaveric way only we are studying. But how the, movement is happening, how flexion, flexibility gives that effect, how the, stability gives that effect and all, we are not studying. So that we should study. This is responsible for the normal function and also the abnormal presentations. So abnormal Vigratam. Vigrati is from the Prakriti, if it were. Restoration of this is aimed in planning and execution of treatment of an IVDP's case. IVDP here I just mentioned, any of these cases. Proper, the intended natural stability, if it is restored, you have done the job. The natural flexibility which is intended, if you are doing, you have done the job. So our aim is to correct that. Modalities, next please. So Pitta and Rakta in all inflammatory conditions, you know that. Vata and Pitta in all degenerative conditions. Whenever we tell about a degenerative inflammatory condition, you know that there is very less scope of oil, massage, etc., etc., etc. We treat it like a Vata Rakta case. Like Rabigata Shofa type of, will come there. And then the other degenerative means we have all the scope of doing a restorative treatment which is told in Vata Rakta. And such conditions. So you can see that even the things which we are using, you know that Shuddha Bala, Kshira Bala and other Tailas are not in Ashtanga, they are told in Vata Vyadhi. It is told in Vata Rakta Chikitsa where degeneration also is occurring. Okay, next please. Lakshanas of Asti Marma. Now involvement, Marma involvement. How, sir, in these cases whether we can do it just like in Kaya Chikitsa, no? We can think about the doshas and dushas only. Why there is an importance for Marma, understanding of Marma. Now I tell that every Ayurvedic physician has the right to do Marma or understand through Marma, because it is not that in BAMS this Marma Vibhaga is not taught and only in PG classes it is taught. It is a part of the syllabus, no? In BAMS. Have anybody told that you should not think in the point of view of Marma or the involvement of Marma? No. We ourselves are feeling like that. That's why I am opening out this. You have to think in that way. So which are the Marmas involved? Please. Vaikalyakara Swabhava. So Lakshanas of Asti Marma, Sandhi Marma and Snayu Marma. Because we are talking about the structure of the vertebral column. Okay. So there are other two Marmas also, which we are not considering here. Vaikalyakara Swabhava indicating predominance of Vayu and Soma. Is there any physiology for the Marma? Whenever the classification is there, it is Sadhyo Pranagara, it is Agneya. When it is Vaikalyakara, there is the involvement of Soma there, Vayu and Soma. Is it not? When it is Kalantara Pranahara, there is the influence of Soma. When it is Vishalyagna, it is Vayu predominant. Is it not? So you know that Vayu and Agni will be predominant in Rujagara Marmas. So these are small lines. That's what I told in the beginning. We believe that nothing has been told. But Acharya has told it. It is our duty to make paragraphs, explanations out of it. Vyakyanas. But Vyakyanas are also, and believe me, yesterday also I told that I make a statement that every one of us have to be a Vyakyada. But if we get stuck with the printed words of only Vyakyadas of that time, sometimes in this world we will not be able to exist. So we have to do that. Then Kadigadarna, Nitamba, Kokundara, Parshusandhi, Amsa Falaka, Krakadiga. Do you remember? All these are the marmas which you have to remember today, because focus is on the disease and the treatment. I'm not going to the details of those marmas. And one thing I tell in every class now, how many of you believe that marmas are points, vital points? Put up your hand. Now if I tell that is wrong, then why do you study the mana? If it is a point, it has to be like the Chinese medicine, acupuncture point. Is it not? Why do you study mana? When we study mana of the Janu Marma, it is triangular. Can it be a point? How far we have misunderstood this is what I am telling. Only, what you call, some are ardhangula, some are ekangula, some are dhyangula, some are triangula, and some are panidala. Is it not? This classification is there. A triangula, can there be one point? So when we are telling about Janu as a Marma, when you learn Tamil Marma, you can see that there are 6 points or 8 points over there. Again, going for the details. But that is within that area. So many things. So you know that now if a knee joint is being discussed, what are all the injuries which are occurring here, what are all the ligaments involved, what are all the bursae involved, what are all the muscles involved, what are all the connections between the bones involved over there, everything will be discussed, no? So it's not a point. I had been teaching like that for 5 years, 6 years, like that in the beginning. Then only this came, that how we can call it as a point, no? It's only there also, Aachaarya has read more things. He tells that Keji Dhanyadu Vadanti, Vrihi Matram. He tells that some are telling that it is like Vrihi only. So Anya Shastram he has also learned. Next please. Tamil Marmam, Male Shuryadi Marmam, Kachai Marmam, Nattallu Varmam, Kaikoti Varmam, etc. So now we will not, this is not the area to discuss over there. Next please. Vyadi Marga, Madhyama Roga Marga, such as the Krachar Sadhyada or Yapyada. Any conditions over in this spinal or vertebra is many a times Krachar Sadhya, because recurrence can be there if not treated properly. Chances of recurrence, requirement of prolonged treatment, resultant disability, rehabilitation. You can see that patient coming with not indicated for surgery but cannot go for surgery. L5, S1, disc prolapse. Or the patient do not want to go for surgery. And we have to be very watchful, no? Otherwise, what the advice have been given by the orthopedic surgeon there? Luckily, we have all scope. Do you know that? This is very crucial, that every one of you, if you start smearing some oil on your hand and start applying on the patient, you have a successful practice. Why I tell? Because there are very less orthopedicians now and more of orthopedic surgeons. There had been more of orthopedic. See, now if you have to see good judgeful orthopedicians, they have to be above 60, 65 now, or 70. The new generation is full of orthopedic surgeons only. Quick fix. This is the method which we can. What happens later? No. Can any orthopedic surgeon tell that, okay, once this surgery is done, nothing will happen again? What about the neurological deficit which will be there? What about the circulation deficit or anything if it is there? Anything is it addressed? What is the strength of Ayurveda? So here I tell a point that Marma Chikitsa is a holistic Chikitsa. It is not that touching some point and then doing some, that is for pain relief. Absolutely, some of them can be corrected. If the Hetu is very less, in one sitting you can correct it also. Because I have some patients who told that, sir, I came to you 20 years back, now I am picture perfect, nothing wrong. You did only once or twice. So that is there. That is because they have the Dhatu Bala, they have the age for it, etc. But not with some other conditions. Okay. So that's why I told rehabilitation also. So always we will have to have some IP treatments. Sometimes it will not be possible with the OP treatment itself. You will have to go for a yoga vasti, is it not? A karma vasti, 7 days of matra vasti, bhalya, that will come. How we will select that. Next please. Okay. So now Samprapti, if you take Kevalavada in Mamsa, Asti, Tarunasti, Sandhi, Snayu, Kandara. For example, if you see the Nanatmaja Vyadis, you will get that. Katiruja, Parshruja, etc. Simple things where only Vata is involved. Kapha Vata Samsarga in all these things. When Kapha also have Samsarga, what happens? We all know that when it is Vata, you have the Sramsa Vyasa Veda Swabha Sadha Rukta Vedanam Sangha Anga Banga Sankocha Varta Harshana Darshanam Kamba Parushya Saushirya Shosha Spandana Veshtanam. These lakshanas we will be having. But when Vata comes, and the Chalatvam is increased over there. When Vata comes, when Kapha comes, the Chala will become Sthira. Stabdada will be more. So those conditions, Kapha Vata Samsarga in this thing, Astidadu Chaya and Majjadadu Chaya. These are very critical conditions where you have Gambhira Dadu involvement, where the bone has become either degenerated, and what is the reaction of the body? To put in more bones over there, no? To stabilize it, osteophytes, or turning the ligament into a bone-like structure. Ankylosing spondylosis, some conditions which are inflammatory first and then goes for like that. All these things can be explained from our own point of view. That's what I wanted to tell. Samata, whenever we are treating Samata and Avarana also has to be considered. This is the skill, basic skill I tell you, because I bow a lot for the Acharyas, because if this was not known, there would be no difference between an Ayurvedic orthopedician and a modern orthopedician. Any condition which is coming, that's what we are telling. When the patient comes, this is the disease, okay, but treatment, whether he is in Sama Avastha or whether any Avarana symptoms are coming, demyelinating, we observe that it does not fall under the normal pathologies. Then we know that there are syndromes. Is it not? Which is there more in explained in modern medicine, which if we read through after the Vadarakta, there is the Avarana. So there if you read through Vyana Avarana with Kaba, Vyana Avarana with Medas, etc., you will get all these conditions. Next please. Okay, etiology now from modern point of view, congenital anomalies, trauma, degeneration, inflammation. Is it not? Is it not? This is what we are also talking about. Endocrinal factors, okay, post hysterectomy, there is loss of, there is a change in the hormonal, this one of the, that results in the, what you call, if there is a parathormone, this thing, again calcium depletion occurs. Okay, occupational and sports. Occupational, my dear doctors, this is the best area now what we are getting. Most of it is due to occupation. And lifestyle diseases starts with the occupation. Because Vega Rodham, Vega Udiranam is the basic lifestyle generating thing, not eating sugars or other things. Because we see that when we are Gramina, we had no problem. When we become Nagariga, for the sake of the decorum of this one, we have to do like that. Somebody feeling like that, that's what I learned. If there is a break, it can be there. Go and come. Because Vega Rodham is the biggest or the first, without even involvement of food, without even involvement of any other etiological factors, your body can go wrong. A body structure can go wrong. So that is why occupational is told. And sports. Now we have entered into the sports medicine also. You know that which all sports can cause, which all damage, to which all tissues more. That is there. Anything happening to the back? Can you tell? Somebody doing a tumultuous high jump, pole vault. You know that how much is put on the spine? When they are landing, long jump, high jump, when they are landing, how much, if they don't know to jump properly, what happens? You know that. Know very well. Next please. Okay, disorders of the neck. Now for you to revise or just to review, you all know this, I need not talk about it, but cervical spine conditions like spondylosis, IVDP, which we are talking now, cervical myelopathy, compression of spinal cord in the cervical region causing myelopathy, or there is a neural compression, the neural signs are there. Stiff neck, postural torticollis, also called wry neck condition, occurs when a baby's neck muscle tightens. Sternocleidomastoid muscle tightens, causing their head to tilt to one side. Erb's palsy and Klumpke's palsy. One is due to damage at the shoulder delivery. Nowadays it is, nobody is going for all the normal deliveries have become abnormal. Normals are cesarean. I am not making an overstatement because there is a matter of fact as far as sir told. No, when we go on to affordability more and more, we have painless delivery where you know that better normal delivery is not needed. We have, and now we have a band of, as I told, old orthopedicians are not there. Now we have more obstetricians who are surgical obstetricians than normal obstetricians. Earlier they used to wait, even after the term is over, they used to wait for 2 days and normal delivery happens. As a farmer, I know that when I am rearing cows, you know that we have insemination date and 280 days we calculate and keep it, but we wait for, watch the cow, and if you wait for 2 more days, normally it happens. Sometimes it happens 2 days earlier also. So natural laws we have lost. We believe that everything has to be as we decide. So these are some what we call biological. We don't accept the biology then. When we accept the biology, we will become more Ayurvedists, I am telling you. Next please. Okay, clumps case paralysis. Next, you know that policeman taking tip and all. If it is the best thing to learn all these things, is go to a simple book on clinical surgery. All these things are there. Next please, dorsal spine conditions, kyphosis. You know kyphosis is, you know that, bending forward. Lumbar and lumbosacral conditions, mechanical back pain. I told this one only, that sometimes lumbago, mechanical back pain is taken as a big issue because you send for an MRI. Now I am challenging every patient who is coming with, who is crying, because many practitioners are there, no? More than the vyadi, the adi is more. Oh, whether it will be surgical, whether I will be ending up with so much of problem, this is the thing. But because a mechanical back pain, like my housewife went to take something and she got a catch. She is around 45-year-old. Naturally, 45 years, there will be some difference in the structure of the discs. Some of the discs may be a little bulged. There will be, this thing also, it will be that mild bulge or moderate bulge only, which is not having any effect on the spinal cord. But once the MRI whole procedure is done and then you have that, this one, they are concerned. Only actually it is like defusing the bomb you have to do. So I tell them that, okay, madam, the husband will be there, or otherwise also I tell that, how much money you spend? 6,000 rupees, no? Will you give me 60,000 rupees and name of 10 best friends of your own age? I will prove to you that some are having a disc prolapse which is much more graver than you, but they don't have pain. Some are not having this one. Very, very plainly tell you. This is the thing. So then, what happens? So then why I did get the pain? Because you bent, you strained your back muscles, and because of that back muscles you got pain. The other one is an incidental finding. Many patients happen that with back pain they go and then they find out, oh, I have a stone in my kidney also. Is it not? Okay, next. So lumbago. Okay, next please, because we will have to go fast because there are something more we have to talk about. IVDP, degenerative spine in general. Now this is a summary. We have already told that spondylitis and spondylosis. What is the difference? Itis and osis. Whether it is tendinitis, tendinosis. One is an inflammatory stage. Another one is due to the inflammation, the degeneration has set in. Osis when it comes like. Next. So sacroiliac, we are talking about ankylosing spondylitis also. An inflammatory arthritis affecting the spine and large joints. Usually young adults, males generally, they get sacroiliac strain condition in which sacroiliac joints are pushed out of alignment. This is called the pelvic distortion. If you go and learn the modern this thing, you say that which actually we were considering. Pelvic distortion, because you've stepped out as farmers, you jump into the field, then you strained your back, and it will be a pelvic distortion, which was corrected by the Vaidya by applying oil, pulling the leg, and done. 2 or 3 days bandage, and that is done. Now that is not being done, because according to the studies we have done, Nidana we studied, passed the exam. We believe in modern pathology only. What are the doshas which are involved over there? As I told, whether there is if you want to loosen it, or whether you want to heal it, whether you want to tighten it, this is what we are looking at, is it not? So those we can add. At that time only we start thinking about the medical part of it also, like whether I should use Kottanchukka Thailam over here, or whether I should use Muruvanna over here, or whether I should use only Karpura Thaila is enough, or whether I have to combine one or two of these things, whether I have to apply it for 5 minutes only, whether I have to apply it for 15 minutes and give a local Potali Sweda or a Ushma Sweda, whether I have to post him for a treatment of 45 minutes, or whether I have to go for a Dhara over there, the affected area, whether I have to go for a Vasti, local Vasti over there, whether I have to go for a systemic Vasti over there. All these things are coming, is it not? So find that how much various this thing we can do. I told just from Lepana to completely rehabilitate, you have to go for sometimes Vasti treatment also, is it not? So much of modalities are there, and so who is more powerful in treating these conditions? Actually we are. The number of modalities, number of methods which are available with the modern is very limited. And why I don't find that only few are having some smile coming in their thing. Know that this is the power we get, that no, we are having more armory than the others. That's why it is going that way. They are suggesting for surgery immediately once it is not responding, because there are no other modalities which they can offer. There are some other issues for surgery also, because bigger hospitals, bigger other involvements. Okay. Now, okay, previous slide. Yeah, congenital abnormalities, lumbar canal stenosis. When both the legs, some people come with that, no? Both the legs numbness. Sir, I am having numbness over both the legs since last few days. Immediately you can find that earlier, did you have any what you call history of spondylosis, or whether you had any sciatica? Then you can see that, okay, then you send for the MRI, you may find that there is a constriction of the space there. So, and other conditions which we should be, now I am finding out, is that when we are treating, it is not getting cured. Some are having severe osteoporosis, you know that, and tuberculosis is one of the hidden things. Nowadays it is prevalent in that sense that the normal pulmonary tuberculosis is not this thing, or that is being, this one, it goes to the deeper dhadus and then they come up with that. So we have to be careful of that also. If it is there, then you have to go for the profile treatment over there. Tumors also, whenever you don't have to suspect, it may be 1 in a lakh, but you don't have to suspect, but you should have it in your mind. Hey, I did my protocol. I did all the best I can do from Ayurvedic point of view, and already modern, nowadays it is known that earlier it was primary treatment. Tadvi Katuga was a primary treatment. Now we are tertiary, because for me at Palakkad, because Coimbatore is nearby, patients come with at least 3 or 4 bags of investigations, because every other modern big orthopedic hospitals are there, and so they come with that. So we are now specialists, tertiary specialists, like, because that is not possible there, they are coming to Ayurveda, Marma Chikitsa, etc., etc. So pat on your back is what I tell. You have so much of this one. Tumors are hidden things sometimes. Age-wise, you will have to see, you will have to suspect whether this one, a male with high PSA and already a history of prostatic surgery and prone for this one, maybe that is the thing. So those things also you have to see. Next, please. Now, pathological events in IVDP, many classes you would have seen, you would have read, etc. That is protrusion, extrusion, intermittent prolapse, scar disc, stage of inflammation, dislocation or derangement, degeneration, spondylolisthesis. You have come across, no? Spondylolisthesis. When usually anterior spondylolisthesis of the L4 or L5 is there over S1. The only test which we have to do is that most of these cases, only 2 tests I do. Ask them to bend, whether how much they can bend, whether it is a normal bend or an abnormal bend. Make them, this one also, if the pain is increasing by this one, by extension, surely you can suspect a spondylolisthesis. So these are tricks of the trade which you have to know. Next please. So the pictures are very evident. Now factors determining the choice of treatment. Considering ours, what we will do, we will see whether the patient is very strong built or very lean built. Whether using a Vadika Kaya or a what you call Mamsa Sarakaya, Asti Sarakaya, etc. Strength, Bala, Alpa, Madhyama, Uttama. Strength of the patient. Sattva in Dashavita Pariksha, these are all included. Okay. IVDP alone are associated with other diseases. Now, IVDP is the star among all these things, is it not? Spondylosis, people start accepting, it's a aging process, it is there. IVDP is the issue there. So, whether the condition is associated with the disc prolapse or not, occupational or not, as I told earlier. Now we have so many cases with the software industry coming in. We have so many cases because 8 hours, 6 hours, 8 hours continuous looking into in a stationary place, looking into the screen, we are putting the body into strain. Natural, it is natural. We should actually, now many of the hospitals have a package for that, like monsoon package. We suggest that every software people who are doing this have to take a treatment to avoid future this one. So that is a big area where you all can work. Next, please. The level of tissue damage, selection of the treatment depends on age. Of course, you agree, accurate diagnosis is what I told. Please understand that I have diagnosed it as lumbago. No, it's not lumbago. It is having some other complication, so it is much more than simple lumbagos. Then that determines your treatment. The level of tissue damage, the grade of neurological or vascular involvement. Underline that. The grade of neurological or vascular involvement. This is very critical. Say in Marma also, no, Eka Marma, it is okay. Sandhi, what do you call, Asti only, it's okay. But if it is involved with Sira and Snayu also, then you know that it's much more complicated. Next, please. Duration of symptoms, personality of the patient, and demand. Demand is also there, no? Nowadays we get patients, sir, I have to go to Dubai. I came for 7 days leave or 10 days leave. I have a back pain, get it treated. Sir, demands are also there now. And personality of the patient. This Aachaara himself has told, no? Vaidhyamaninam. Some people come and tell that. Many a times, one thing I tell you is that when a patient comes and tell you that I am facing this after 30 years, 35 years of practice also, patient will come, they will come and ask that, sir, or L5, S1, IVDP, sir, chikilsichittundo. You can expect that. You can expect that. Then I tell that, I receive all the records. There will be our Shishyas or the other doctors also there. I hand it over to them. Please make a record of all those things. Then I examine. I ask them first that only. You start asking like that. Whether L4, L5 is your problem or what problem you are having. Then only you will be able to understand that. Okay, I am having ache when I am getting up. Okay, one thing. I am having ache when I do something more. That is another thing. I have an ache which radiates to the leg. Okay, that is another thing. So now our patient behavior also we will have to manage. So that's what I told. Personality of the patient sometimes will make our decisions wrong. Don't fall prey for that. You have to have your decision. Conveying the decision and appreciating their concern, that is your job. Because you have to be the Vaidya, the Rogi has to be Bishak Vashya means, every session I tell that you have to know the Vashikarana way. That's why how much you have studied, you will become a good practitioner only if your body language, your spoken language, etc. is concerned with the patient. In concerning, I am a big doctor, you come and go, whatever it is. If you are like that, then you know that you are not being Karuna, you are not being Mrudu, whatever Acharya has told. Bhutanukampa is the first thing, whichever chikitsa, especially Marma chikitsa I am telling. Okay, next please. Treatment principles. Treatment principles of Vata Vyadhi, Bhagna, Marma, Bigada, Shofa and Vrana has to be applied in all these conditions. When you stick up to one thing only, you are losing the other modalities. So that is why the question comes that whether traction we can do, sir, whether we should do, sir. Traction, if it is distraction, traction means distraction, is helping in that, resolving that condition, why not? Anchanam, whether it has not been told, when Adikshiptam it is, Anchanam is the method for spontaneous reduction. So that can be applied. So that is why Marma Chikitsa also, Bhagna Chikitsa is also told there, Marma Abhigada Chikitsa and Shofa Prana Chikitsa. Shofa Chikitsa. Apatarpana, now, sir, we expected something different from you. Maybe it is that, means I tell you very plainly, that's what I told, that some tricks of the trades, whatever that massage methods, etc., will be showing. But basically that's what I told. If after the Shashti Rupakrama, if you are not knowing where Apatarpana will help in solving the back pain or the neck pain, we are failing with all the other treatments actually. So right from Apatarpana, Alebana, Parishega, Abhyanga, Swedana, Vimlabana, Mardana, Upanaha, Visravana, Snehapana, Virechana, Anchana, Bandhana, Veshtana, Kavadashayana, Snehavasti, Kashayavasti, Kativasti, Shamana Ushadis, and immediate Agni Karma, Vidya Karma nowadays for pain management, and Asti Dhatu Vriddhikara Chikitsa. This is the package along with whatever we are doing physically. There are some physical methods are there, other things are normal treatments, you know that. But how much, now I am telling you, I am just opening the Marma scope. How much variety of treatment we can do, have you thought about that? If you know that, you can see that this much varieties of treatment can be applied for these spinal conditions which are cervical, dorsal, low back, pertaining to the leg also, sciatica also. So remember that in that Veshtana is coming, Bandhana is coming, is it not? What is the difference between Bandhana and Veshtana? Veshtana is, why you, the dhoti you call it Veshti? You do Veshtana with that. Okay. Tight bandage which is being done is Veshtana. All the, now you see that so many gadgets has come, lumbosacral belt, this different types of belts and corsets are come. All are for Veshtana only. If it is useful, if you have to use it judgingly to that much time what is required. By the time you do your own treatment. Okay. Next please. Now classification of patients for Ayurvedic treatment. This is what has made me, my teachers have taught me, or from my teachers this thing I have derived out. This is the only formula I am using it. Vignesh, this is the one which I use it. Classify the patient, understand the disease in the basis of, based on occurrence, mode of onset, acute onset. If it is acute onset, patient is coming with acute pain of the neck, back, low back, sciatica, etc. Bhagna Chikitsa, Marma Abhigada Chikitsa, Abhigada Shofa Chikitsa. What is that? Price. Positioning properly, giving the proper rest, and giving the proper, whichever, if it is immediate, you have even application of Shita Leba Sega, the nice. In sports management, sports back catch and all, immediately for the first 24 hours, the treatment is keeping Shita Chikitsa, because to reduce the hematoma, hemorrhage over there, and do the, what you call, giving the proper rest. Immediate. Onnu tadava, pidichu ketta. Tadavi ketta. So there the relevance is Marma Bigada. There what happens is that when they come to acute pain also, we are sitting in the agency or we are sitting in the in our hospital, we start writing sometimes what you call a big prescription. And by that time the pain is the biggest concern. Vyadhi is the Upadrava is the best thing. What has Acharya told? The Upadrava has to be dealt first. Pain management has to be done first. So Bhagna Chikitsa, it comes over there. Next is gradual onset. It is simple Vata Vyadhi Chikitsa, whatever has been told, the modalities which we have told. Then gradual development but sudden onset, a combination of both treatments. That is acute upon chronic. Your patient, you would have seen that 10 years back, he had a back pain, he was very happy after your treatment. After 5 years, he come one day that, sir, I am having again back pain. So that was already, you know, that chronic condition is there. In that an acute incident occurred. It's very quite common in Palakkad. Yesterday, even day before yesterday, one patient came, old farmer, because the planting, this thing has started, tilling has started. He told that everything was okay, sir. I wanted to fertilizer one bag, I lifted. Again, I got acute upon this one. There, a proper this thing of Marma Chikitsa and Vata Vyadhi Chikitsa has to be done. If you know this sutra, then done. Any this thing you can manage properly. Recurrent, all the above plus Balya, Stairyagara, Astidadu Chayahara, Rasayana Chikitsa. The biggest Rasayana which we use from our teachers' time itself is that Gugulu Tikta Gradam, which is told in Vadrakta, which is for Majja, Asti, Mamsa, Meda, all these conditions which involve this one. So rehabilitation in that is being done. You can use drugs like now Karaskara Grada also for many times, which is involved with any neurological deficits, etc. Okay, next please. Options in modern medicine: rest, medication, orthosis, exercises, manipulation and massage, and surgery. Now in this class we will have to talk about the manipulation and massage, which is expected from me also. Okay, next please. So treatment of Marma injuries are difficult to cure completely even if all efforts are taken, unlike injuries to other parts of the body. Agreed? Because it belongs to the Madhyama Roga Marma. Requires utmost skill and good knowledge of Shashti Rupakramas. That's what it will. We just tend to forget the Shashti Rupakramas and then tell about Marma Chikitsa. No, it's a part of it. And then you see that, so skill development is very important. I request every opportunity of any organizers that skill imparting, this one should be more done in our system now, because there is no time for skilling during our regular course. Skilling comes after that only. So we all got skilled during the internship program. Only 6 months it was there. During that time, after the hours, because therapists were less, Jayachandran sir asked us to do the massages. He told that I will teach you that, and then we started doing it. Raju sir told about management of the fractures or the acute conditions, injury conditions. We started helping him. So after that, PG also we went to, and then so you can see that, and that's what I told, that how many of you are ready for putting some oil on your hand or touching the patient? Every one of us, if we are ready, then there will be lots of patients. Because your hand is itself, you know, the sparsha of your sparshanendriya on the sparshanendriya of the patient will correct the vata. Because vata is the place for, the tok is the place for. No. That connection is there. So that is very important. So usually we prescribe, after I see a backache patient, nowadays my juniors are there, so it's okay, but otherwise immediately drop the pen, go to the examination table, do the thing, and then get off, and then give the prescription. This will be the method. Nowadays I tell that, okay, you do that, you do this, like that, and the juniors are doing. And whenever it is needed, even in the IP also, when the therapy is going on, you should be keeping to that level. Let the therapist, what you tell, if they are very trained under you, let them do it all over the body. When it comes to the spine, you just tell that, make the patient lie down on the back, call me. And then you should do it. What to be done, how to be done, I will show you. Next. So that's why now itself you are seeing a picture. And this is a part of training where how much pressure has to be given, how much pull has to be given. Actually it has to be taught by the Vaidya himself, making the person who is learning do it on the body. Next please. General principles of Marma treatment as far as these spinal conditions are concerned is Santvanam, I told no, starts with the vocal anesthesia. Others are having general anesthesia, regional anesthesia, local anesthesia, which we have to take a permission from them to do that. But we have vocal anesthesia, no? What has been told? Purva Vivashi. And the patient comes itself, if you know that you are having some problem there, no, the patient is immediately this thing. So we will have some solution for it. If you tell, half the thing is over. But if you go on seeing the MRI, oh, what the doctor told? Oh, it's a very grave condition. Whether you will be able to deal with the patient? No. Santvanam is the first thing. And don't be bluffing. Be truthful. Be truthful. It grade 4 IV this thing with a tumor in this one. Tell that it's beyond our this one. Some Santvanam, some palliative treatment we can do. Along with that, you go for rather palliation also. That we can tell that. So Snehanam, you know that. Jivaniyam, Brahmanam, Stambanam. Then Ropanam. Vadapittagna Chikitsa, Balya Rasayana. So this also gives you I wanted to give you modalities which can be used. What is the thing for that? Remember that each and every patient in you does not require all the treatments. Each and every patient coming with this spinal, this one, may have to have a combination of this treatment or the selected modality only. Next, please. Next. So methods Abhyanga, Pichu, Lebana, Bandhana, Veshtana, Trasana, Seka, Shirovastinasya, Karnapurana, Pindasveda, etc. So here end up with Pindasveda. Here you see a bandage being done for a dorsal. This is he have jumped from around 12 feet high, and there was a compression fracture of the D12. And so after discharge from the hospital, initially they suggested some surgery, etc. And then because he was faring well also they have discharged, but he still had pain and other conditions. So then you can see that this is a Marma Bandha Veshtana, where you see that both sides, from both sides we tighten it, not just from one side. Okay, by giving Pichu Bandha, etc. Okay, next. Trasanam, you saw that. Trasanam we will be talking about in Adangal Jigilsa or Marudattu, Tattu, etc. Now Ayurvedic Marma massage techniques, now the many methods are there which I have been giving in many classes. Earlier also I have told about it. Is Abhyangam, Mardhanam. So sometimes we feel that this stroking is only our speciality. Abhyanga you see, any hospital you see, just it is a stroking massage. Mardhanam, that is not told for us, sir. Mardhanam is some Kalari method or something only. That's what we feel. Pedanam or Avidanam is not our method. But in our Shastra you can see that Bhojyani, Abhyanga. Next is what? Mardhanam. When there is, and when Kava is involved over there, you are told to do Unmardhanam. It has to be pressure massage. So it is there in the textbook. Again I come to this one, Nidra Nasha. I told no, diseases started in with the disturbance of Vata in the Vega Udirana Dharana only. What is treatment told? It is Samvahana. Samvanam is the best treatment. Talodalana. If you give a comfortable massage to the patient, sleep will be induced. Is it not? So many methods which are told here are not just out of fashion, but it is there in the textbook itself. Like Udvartanam, Garshanam, Udgarshanam, Garasadhanam, Ladaveshtanam, Pedanam, Avapedanam. Next, please. Anulepanam, simple application of oil. Padabhyangam, Karnabhyangam, Shirobhyangam, Udveshtanam, Padagadam, Sandilepanam, Sandam Shiga, Keshamardhanam, Phenagam, etc., etc., etc. So which everyone knows that this is being practiced also. Just I wanted to tell that these are different methods as told in the Ayurvedic Samhitas, where you get it. There are different places where you work with different things. Next, please. Tamil, this one, it is Tattal, Irukkal, Pidithal, Murukkal, Kattal, Aduttal, Iduttal, Malarthudal, Asaital. These are the Tokana methods or the Varma treatment methods. Another 3-4 are there. Where you know, if you know Tamil, how many of you know Tamil? Yeah. So you can see that these are the methods which this thing with stroking, clinching, kneading, twisting, locking, pressing, pulling, stretching, shaking, etc. Next, please. Kerala massages. How many of us have thought about now? Let the people in the north. They are all attracted to Kerala to learn Ayurveda Panchakarma treatment, etc., etc. How many of us know the difference between these modalities which we tell that, we sometimes tell that this is only the language difference from North Kerala, Central Kerala and South Kerala. As a Marma specialist in the ISM department, Indian system, some of them are there from our department here, working also. We Marma specialists were called Urichil Vaidyar only. Very happily I can tell that sometimes we were Urichil Vaidyar, it was a very, very, what do you call, because Vaidyas were always made fun of. This is that Urichil Vaidyar. But see that if you understand the meaning, then we know that we are very, very technical people. I was proud about that because I do the Urichil. So you can see that there is Tadaval, Tirumal, Urichil, Chauti Urichil, Talodal, Tattal, Tepu. Tepu, everybody knows now. Tepu Kada I saw here when I came here. Tadaval is a stroking massage. Tirumal, whenever Tirumuga it comes, there is a rotatory movement over there. Tirumuga. So that is why Vartanam, Udvartanam, Udvartanam. Udvartanatulakke, in all those things we have to do a circular upward movement with pressure. So Tirumuga is in this one. Urichil is according to the contour of the muscle, according to the contour of the shape of the muscle, according to the Langer's line, according to the Anulomanatum is by the hair, this one, no? So the hair is showing this thing, the interior Vada Chalana is being shown by that. So following that, the Urichil has to be done. So it is according to the contour of the muscle stuff, or if it is a limb, it is a long drawing massage. If it is a flat this thing, then you have a flat this one. So that technique has to be. So the Urichil, the expert in Urichil is expertised in the massage method. The others are only doing Tadaval. Okay, next please. Then Talodal, you know that very, very, very gentle massage is Talodal. Tattal is whenever you give a hard beating force on the portion. If it is very, very numb, any portion which you get numb, what you do? We pound on it or we slap on it, etc. Those are the methods. So in Marma, it is very important. It is Marma massage. It is very important. What is that? Marutattu, it is called. For example, simple thing I'll tell you because today time is very less. I can go on for 4 hours, 5 hours also. But simple thing is whenever your own child is not feeling good, is very depressed or this thing, what you do? Or sir is there, his deputy is coming to the market is very less, sir. This is a lean season, sir. Then what he will do? Okay, you try your best and then what do you do? Put on the bag. Okay, let us see. Rainy season is coming. All these Vaidyas will be very busy. We'll get back the market, no? You put the back. What you are doing? You are just doing a Udana increase. Because Bala, Varna, Smriti Kriya, Urja. You are doing a pat on the Sadhaka Pittasthana, which is again Buddhi Meda Abhimanadyehi Abhipredartha Sadhanat. Did you connect all these things? It has to be. So that's what I'm doing. Look back into our own Shastra, look back, not look into our Shastra, and then many answers we will get of what we are doing. So Chauti Urichil, you know, Tattal is that, and Tepu is generally apply. When you give, you don't have to do anything. You have a small pain only. You take a little Karpura Thaila, apply it, and then wash it off. So that is Tepu. Next please. So we are just now showing some pictures. Piedanam, you can see the hand movements because here demo cannot be done. This had been shown in my previous class also, I think. So just to get a catch of what is there. Next please. Paripedanam with a reinforced pressure massage or press on a particular area. All these things are showed because I will be showing a video of back massage. But these are the basic movements or basic templates, basic methods which has to be understood. And then this is, you know, that stroking. Palmar stroking, Samvahanam, finger stroking. Use the finger only. Whenever you are using the finger, you are having very less pressure. What makes the change in the massage or the press or the treatment you are doing. It is the pressure which you are giving. It is the rate in which you are doing. Whether you are doing it in the Mandagadi or in the Drudagadi, Druda Vilambida, Go Bhavadi. So you know that what you are doing, whether you are using a heating agent along with that, whether how much duration you are doing, this all determines the effect of the massage. Next please. Beating Tharanam. Next. Thanks to CCRAS formed a core committee of Marma Chikitsa experts, and this book is now second edition is available with CCRAS. If possible, you all get that, because if a private publisher, if he publishes, it will be 6 volumes, 6,000 rupees. This is only 1,200 or something. Because we could organize such a thing, and now Marma Chikitsa has a basic textbook or reference book, not textbook I will call it, reference book, which is very, with all the plates. These plates are from that, so that is why I am telling you. This pounding, next. So here also you can see that whenever we are doing that, a Marma person, you know that how he holds the limb. You can see that every hold has a, now where is my finger locking? These are the important things which whenever a teacher tells you. You go on like learning from the Drishtakarma also. If you don't apply your mind, you will not learn it. So that's how we are able to even what you call pain reduction of fractures of the upper limb and all. Without giving anesthesia, how we are able to do that? Because we were not told. What our teachers told that, okay, you catch it here, one of them catch it there, that finger should be there only. If Raju sir and all, when we are doing, if we change the finger, you will be very upset, because that portions were the Marmasthanas, Manibandha, Bahui, and then pull it, you can manage it very well. Like that, I have seen very, very severe Khalli patient, not able to come walking like this, and then not able to come, just press on the chipra and then slowly release it, you can get hold of that. So these are practical things which you have to learn. Garshanam, Talodal is gentle massage. Next please. So, grasping, whenever there is a pain, if you like, this is grasping, another grasping which we did. Okay. Udvartanam is always upward stroking with a movement, rotatory movement. Anchanam is pulling. Many times limb shaking movements are given. Kodaiga, in Malayalam we tell that. So for that, this one is there. Before that, Anchanam is being done. Pulling. Next please. Yeah. Mardhanam is squeezing massage or pressing with this one. We tell that whenever we have a, this also, any patient who comes with cervical pain, after you find that, okay, you've written the prescription, just put your hand over there, which side it is paining, and then on the other side also. Then give just 3 squeezing massage over there. Immediately his eyes will become bright. I guarantee you. These are the things. So when you are trained in that, when you are applying this Marma scope into that, the patient, when he is getting up before the consultation and after the consultation, you can give the Saukya. So that's what I'm telling. So methods are simple, but whether we are doing that is the thing. Next please. This is Vimlapanam. Vimlapanam everyone knows, no? Angushtena, Talena, Pani Talena, Venunava, Mardhanam. So some of the, in Kalari Chikitsa, in many Marma Chikitsa area, you go and sir, they are doing with one rod, they are, what you call, in the painful part, they are rolling the rod, etc. You can see. That is Vimlapana. I tell you that now fibromyositis is a big issue. Fibromyositis, Vignesh sir, I saw that like Parkinson's Society, they have formed a fibromyositis society also, like, because they all don't have solution in US. So I have dukkha. Oh, you are also having dukkha. We will share our dukkha's. I can guarantee that every Ayurvedic physician, not Dr. Srivats, any Ayurvedic physician following the classic traditional route thinking can solve it very easily. Because what we have to do is that the patient comes that every time I get a swelling, this one here, I am not able to move, I am not able to sleep, I am not able to work, cranky. It is typical Mamsagada, Snayugada Vada Chikitsa if you are doing, including a Virajana, if needed, I was done. Guaranteed. Which is a very, very big, unsolvable problem in modern medicine. That too with the ladies in the menopausal age. I tell you that. We have to think from our own point of view. If we just see that, okay, you are healthy, you are only 37. But what the problem you are having is because of these things. I will do it. You go for what you call Mamsakadavada Chikitsa is what? Snehanam or Ruchanam, whatever is indicated. Snehanam has to be done, followed by Swedanam, followed by Virejanam. Sir, this is an orthopedic problem. Virejanam is for Pitta, sir. What is this? Then we are actually becoming reductionists. We have to understand that there is an inflammatory condition over there, which there is Amapajana we have done, and then it has to be removed. That's all. Setting the situation. Okay, next please. Now where is my hand? It is in the Indravasti Marma, Avapiyadanam, stationary compression. Very good, effective in Gridrasi. Very effective in Gridrasi. While examining the patient also, you see that he is having pain and he is having, you do the SLR test, you do all the other tests. He is having what you call EHL weakness. You are testing for that, whatever it is. You check this point, it will be painful. You ask him in the night, sir, I am getting the pain there only. Tell them. Okay, next please. So I know the time is up now. This is Marma Aruthal, or we call it it's in Tamil Nanganam Puttu, where you know that the Kadigadar, a place where, or Kukundara, place where you put your, this one, and then you rotatory movement. Immediate effect will be there. The patient is coming with back pain. At least you can tell that, no, it's not a big, what you call, easy issue. I can treat it, but now he comes like that, but you do this, he goes back like that. Many videos, now reels have been, many of the new practitioners have putting reels. Many of my students also are who came from North, they are very much utilizing these reels, Instagram, for popularizing these things, because they become popular and Shastra also become popular. I tell that you do that because people will know, because nobody is going to read the book, they are going to watch this one only. Let them get informed. Next please. Okay, this is Aachaara Thirumal, which is a Kalari Thirumal. You know that at one place itself, it's a stationary kneading. Next please. Tattal. Next. You know that sometimes this is not enough. You have to give a blow with your Urpara itself. Next please. Irkal. It is being done. Next please. Again, Murukka, there is a twisting movement also. You do like this. No? You catch the muscle bulk and then rotate it in your hand or push it in your hand. Next please. Idathal is every patient nowadays coming, many of the ladies, no, or gents also, with heel pain. We all look for calcaneal spur, whether it is, or retrocalcaneal bursitis, or fasciitis, etc., because we think in that this one only. But if you see that there is a little shofa in the surrounding tissues of the Achilles tendon, and that once it is released, she is becoming pain-free. You are not doing anything, you are doing calf muscle press and then doing a massage over there. Next day she is telling that, sir, it took 10 minutes for me previously, now within 2 minutes I am able to get up and walk. So that's what I am telling, study it in our own way, the pathology in our own way, then the tricks are also there. Otherwise it will not. Next please. Okay. What I tell that these are all you do for yourself. Next one. If you are before going to sleep, pamper yourself is what I tell that. Because you are working whole day, no? As a doctor, as a this thing. Just put your leg over in your thigh and then give a amartal like this, press this thing. You see that you get relaxed immediately. Okay. So this is, whatever is relaxing for us is relaxing for the patients also. Sciatic patients who are sleepless, I ask them, who are bystander over there, you go on doing these things, the Indravasti, the Chipram and this one, every hour, every 2 hours, you just give a press and release. Patient will be calm. Next, please. Okay, treatment, internal medicines given by oral, external treatment given by on the site of the Marma injury or Marma disease. Psychological and rehabilitative treatments are also advised. Sattva-vajaya has to be done along with Yukti Vibhashraya Chikitsa. Then only you are successful. Many times it is like that, no? If you are a expert in that, people come with a belief itself. That is half done actually. So try to make it. The patient should believe in you. Then only it's so Sattva-vajaya is very important in that. Next, please. Aushadha yogas which are generally used is all the kashayas and tailas which are used in vata and vata rakta can be used in all these prashtavamsha conditions. Marma Gudiga is used for leba. Nagaradi leba is done, or Manikundurikadi leba it is called. Marma kashaya or Nadi kashaya, all these medicines are there with companies like Sitaram, which are very, very commonly used for this chikitsa. So what makes the general this one? So for example, sometimes it is when I will give Rasaayanam kashaya, maybe in a subchronic condition. When it is an acute condition, Nadi kashaya. When it is a chronic condition, sometimes Dhanvantaram kashaya or something like that. Upon that, we will have to go for Sahajaradi, Ashtavargam, etc., etc. Bala Sahajaradi, etc. with Bala Tailam or something like that. So that variation comes like. Murivanna and Ashwanna, Murivanna I need not, I have to be thankful. If we are using Murivanna, that is thanks to my teacher, Dr. G.S. Raju. Thanks to the Ajay Sar's grandfather. It came to the Ayurvedic, this one. Now it is one of the best selling medicines. But sometimes we are overwhelmingly using it. See, it is a taila which is good for chada, marma chada. The combination is such that you have the kalka as shatavari, which is vata rakta, this one. But nowadays, for every pain, because somebody tells that Muruvana is the best painkiller, but it's a magic oil. I tell you, it's a magic oil. But you can understand that, okay, if you feel that, okay, Muruvana, no, Cotton Chukadi has to be used, you use it. Because you should know what is Cotton Chukadi and what is Muruvan. So the other one is Ashavanna, that is what I called. Ashava in Tamil is giving relaxation. So whenever there is a contraction, Ital Masha Saindosa Dailam Sanko Javadaharam. Like that. Do we have any Ashavanna? You tell that I was talking like that. No, it is there in the south, this one only. Ashavanna, we don't have such a thing like that. I think I was talking. After that, once analysis was done, you know that Parinata Gairiadi Daila, which is done in Apabahuga, where you are not able to lift, which contains Amla and Sarjarasa. This one. Chinjadi Daila, wherever Amla and Lavana comes, there will be Ashav. Kottanjukadi is another Ashavanna. Stiff knee. You apply sincerely 10 minutes. Kottanjukadi massage, simple Kottanjukadi massage, morning and evening. Flexion will improve with first sitting itself. After 5 days, flexion would have improved 50% or more because it's an Ashavan. At that time, if you put some other oil, the Snehana will be there, but you will have to think what is needed at that time. So that's what I'm telling. Okay, next please. Tamil Varma Shastra, Adangal Prayogas are there. We will not come to that. This one in Kalari Marma Chikitsa, I told no, Marutat methods are there which are part of this one. So it is also sometimes required in our this spinal conditions also. Somebody has fallen down from a height. Do you think that it is only the spine which has been damaged or vertebral column which is suffering? What is your answer? No. From that day onwards, for him, there will be looming whether I will fall down, whether I will fall down. Next, what will happen? The fear would have conquered him. So that's what I'm telling, that you have to have a different. So there, even sometimes you know that these Urichil, these methods which are being done, a tap which is given there, changes the prana to the proper place. Because the prana is dislocated. Now we call dislocation only when the bone is dislocated. But there is an inner thing which is happening where the prana is also getting dislocated. You bring it to the location, that is, do a anuloma massage according to the Gadi of the Vada, remove the Margaroda, bring it back to that, done. Next please. Okay, next. These are the Tamil varmas which are usually used for neck pain. So those who use this one. Otherwise I tell that go to a good teacher and learn Tamil varmology also. And get a hands-on training from them. We can also help a little, but Gurumukham is something which is different. Manibandha Varmam, Mudichu Varman, Kakatay Kalam is neck for neck pain used. Mudichu Varmam, Kakatay Kalam, Chavu Varmam, Kauli Kalam is used for neck pain radiating to this thing. Here only one this thing is for those who have not attended Tamil Varma class. Manibandha Varmam, everyone knows that. Mudichu is this, I told no, C7, D1. Kakatay Kalam comes like near to, on the anterior side of the Amsa Marma. Like. So many of the Tamil Marmas are similar to our Marmas only. In our Shastra, Marma manipulation has not been told for curing anything. It is from other Shastras only we have to understand. But without knowing, I put a question. In a process of Nasya even, how many Marmas knowingly or unknowingly you are touching? Can you just open your Marmascope and then you will be able to understand that. Okay, I think time is up. Next, please. Restricted movement of the neck, Mudichu Varmam, Kakatay Kalam, Thusimukha Varmam. Now, neck pain radiating to shoulder. So, just I wanted to introduce to you that learning these Tamil Varma Chikitsa also will be very helpful in our practice in Marma Chikitsa, which sometimes we are knowingly, sometimes unknowingly. So most of the times we are doing Abhyanga, we are doing it unknowingly. What is the secret behind it, we don't know, but our hands go there, do the job and do it. Next is, okay, next. Tida Varmam and Kaimuttu Varmam in pain of forearm. Kaimuttu is, you know that whenever Malayalam you know that it is the Marma in this one. This is general pain in the upper limb for frozen shoulders and neck radiating pain to the shoulder, etc. Chavu Varmam and Kavali Varmam, which is Shipra Varmam and the Lohidaksha Varmam. If it is pressed and released, you will get that. Next. So these are the, you can go through because it's already time. Now back, there are, now for you to believe that, okay, these are the things which are being done in Tamil Varma with very good effect. These are the Marmas which are, Ullankal Vellai Marmam is near the Talahart itself. Mannai Varmam is near the Indravasti. Next please. Next please. Okay, now this portion will be dealt in the evening class, I think. Physiotherapeutic methods, kinesiology, etc. I'll just introduce some of the words which, this is myotherapy, musculoskeletal physical therapy is very important. This is where I told that in modern physiotherapy, these things are there. But for us, these methods we are doing during Abhyanga with all those Abhyanga, Mardana, Pedana, etc., Anchana, etc., which that's what I told in the beginning of the class. It's not recordically told like that, so but they have the Syriax approach, Carlton Bones approach, Maitland approach, Mackenzie's approach, Kalari massage procedures. I think next please. This also I just introduced spinal kinesiology. Now that's what we are learning in our, typically what is there in the MBBS course, we have been adopted to see what you call BAMS course, and we are learning cadaveric anatomy, which is useful in one way. But for our practical purpose, we should learn kinesiology. And spine kinesiology is a specialized field of study that focuses on the movement and function of the spine. It involves the application of kinesiological principles to understand the mechanics, dynamics, and control of spinal movement. Did we talk about the flexibility? Did we talk about the stability? We are talking about it. But when we put it into new words, when we align with the new science, then we know that we are scientific. We can tell that we have a scientific approach to it. Next, please. Okay, then this is the detail. Maybe it is coming in the next classes. Please, so you can see that it for spinal rehabilitation, injury prevention, sports performance, clinical assessment and diagnosis, thinking in the way of, I told about Marmascope, no? Marmascope gives that chance of thinking in the kinesiological way, how the movement is happening. When the movement is there, where is the load coming? Which is the fulcrum over there? These mechanics we will start thinking. Next, please. Next. Okay. Who are using it? Physical therapists. So we have to become and our paramedical workers would have to become knowing about these things. Actually, in the Kalari Chikitsa and all, you know that it is the action. In the action, something happens, it is done. More of action is there in the Kalari Chikitsa, etc. I told no, because we are satisfied with the stroking only. But only Marma Chikitsas, we do all the other things. Next, please. Okay. Now, you can go. Exercise programs and all, how we can do. Now, which are the conditions in which it is useful? Herniated disc, spinal stenosis, scoliosis. Next, please. Next, please. Improved pain management, improved function, injury prevention, enhanced quality of life. Helps to improve overall quality of the spinal health. Now, the thrusting manipulations and all. Now, massage we are talking, manipulations are there. I will show in the video. There is high velocity, low amplitude, HVLA. There is a low velocity, variable amplitude. I think all those things will be discussed in the class which is coming. Soft tissue mobilizations. Spinal manipulation therapy. As a Vaidya, as a Ayurvedic person who is having an advanced approach, you all should be knowing it. These words which are used in physical medicine. That is why I am showing it. If it's a different class actually. Chiropractic manipulations, osteopathic manipulations, physical therapy manipulations. So physical therapy manipulations include all those things. This all, you know that this is for better function, improved pain relief, improved function, improved health of the spine, etc. Next, please. Contraindications such as osteoporosis, spinal fractures, etc. So we have not talked about the spinal fractures in this class because again that is a big area. Okay, there also you can see that patient selection. It's essential to consult with a qualified healthcare professional to determine the best course of treatment for your specific condition. That's an instruction to the patient actually. Okay, next. So before ending, I will tell that this is the gist of it. For a Marma physician, for every Ayurvedic physician who is using the Marmascope, it is that he has to, Ayurveda is Marma Paripalanam. Ayurveda is Marma Paripalanam because prevention is first thing, Abhada Varjanam, Nityam Swastavartasya Anuvartanam. Somebody will tell that, sir, for Marma people, this Swastavrata and all, what is that? Very essential, because if you are able to do that only, then you are able to convey it to the patient. Nityam Swastavartasya Anuvartanam, Utpannarthi Vigadanam, Marmanam Paripalanam. So there is the Paripalana of the Marma which has to be, and you know that though so many points have not been, if you learn Tamil Marma, both the sides are, when you learn about Krikadika, when you learn about Kukundara, when you learn about Nintamba, when you learn about Kadiga Taruna, you see that Pushtavamsha Ubayataha, it will come. Amsa Falaga. So you can draw two lines in the middle. You can take this middle of the clavicle and draw a line. You can get all these marmas on both sides. In the front you can see that you will get the Stanarohida, Stanamola, all these points. So have a lot of imagination is also required to see that how these things are involved in the function of the spine, etc. Thank you very much. Okay, this is, as every time I tell that, ignite within yourself the Torah. We tell that the Dhyartitvam in that. Inquire a lot, invest a little time for that. You involve in that and then imbibe it into your practice. Next, please. Okay, you know that beneficiaries are many. Like you can see the MP over there. And welcome to uncover this approach. And once you uncover it, you will be very much benefited. We can stop there, can play a video for a sample from that. Oh, 120. അതിൽ തന്നെ ആ ഫോൾഡറിൽ തന്നെ ഉണ്ട്, 3 ഉണ്ട്, അതിലേതേ ഒരെണ്ണം പ്ലേ ചെയ്യാം. Okay. See that how if you know in your mind if the marmas are there, in that how your hands can move. And this one you can see that this is also a demo in the National Institute of Panchakarma. This is the last, not in the lying down position, one in the lying down position. You can see that whether what all movements we talked about, Kurichil, the what you call Tirmal, all the movements, as well as from the Griva to the Prishta, through the Prishta to the Kadi Pradesha. That Marma Arutal I showed that, but in action how it is. The Shroni Pradesha is involved usually, even if it is the L5 lumbar vertebra only, the Shroni Pradesha will be, pelvis will be affected. Pelvic functions also will be affected. The Apana will be affected. When you correct the Apana, this one will be. So correction of Apana, we always believe that, okay, giving Erandadaila is the only thing. Like, no. If you stimulate this one at this chakra, then you know that you get it. Your hands will start telling you, oh, this is the harder area, this is the relaxed area, this is the spasmic area. So then accordingly your hands start moving. What Acharya Sushrita has told, Hastameva Pradhana Tamam Yantram. Empower your hands, then you can do a lot. This is Kiri Kuttana, we call it Uriya Kiri Kutta. Same thing which we are doing with our. There we do it with in Kerala and all, now we have got the practice of the Pinda Sweda with which this is being done. This will give the total relaxation of the back muscles. Then once the muscles are relaxed, you know that even the little prolapsed disc will go into its normal position. It's not pressing through. You harm anything, you do hard anything, it is not going to. So once the surroundings are relaxed, then you know that. Okay, another also, because that will be informative. So this is running in 2x so that we can finish it. Now this is also a spinal injury patient where this adangal is done first and then and I believe that anytime you have to be in this one only, don't wear for this seminar only I wore a full cuff, this one etc. But be ready with, you should be very ready. So go for Kalari, go for dance class or Zumba now, they are telling, very hot. Whatever you do, make yourself agile, fit for this thing, because once a massage is done, there should be a choreographed this one. This rhythm, getting the rhythm for Vata in the patient's body. It should be rhythmic. Your hand movement should be, you should be concentrating in your connection with the patient, not at the Dhatu level, at the Manas level and Atma level itself. So usually nowadays after retirement I am very happy to be in my dhoti only in the clinic. You get see that there is all mobilization of the paraspinal muscles, because when you could have seen that he is like this only now. And many a times the new gen is afraid of, sir, already there is a disc bulge, sir, if I touch what happens, like this one, wrong hand, of course, that's why we tell that you get experience, you get doing small things and then coming for bigger things. So here we know that sometimes if it is, okay, marma chikitsa, marma, pressing marmas and all are not told in our shastras, sir. You are claiming to be marma. This is the Kerala marma chikitsa. So that's what I am telling, knowingly or unknowingly. But when you know that these are the marmas, okay, you are pressing at the natallu marma, you are pressing at the mudichu marma, we are pressing at the amsa falaga marma, we are pressing at the amsa marma, then we know that, okay, we are pressing at the massaging at the kukundara, we are massaging at the kadigadarana, we are massaging at the parsho sandhi. Then we know that we are pressing at the nitamba marma. Then we know that, okay, it is within that. Something is not told. That is why it is called marma. We have to understand. So I am opening out that. Now this is a bandhana which you know that it can give a both shoulders. This one figure of 8 bandage. You can see that. Then I will go there and then come back enveloping the other shoulder also. So the patient after that will be very, very comfortable. No thoracic corset or anything, tailor's corset or all will give this happiness or this comfort. We are giving pichu also, Murvanna pichu also. Okay. I think there will be time for the other one also and then we will wind. So this is a sports person actually. Evaluation is very important. I could see that that right side, that muscles were very, very taut. He was a thrower or something, I think. See that what all positions you can bring in, like when you are massaging too, if you understand there is any difference in the alignment of the spinal muscles or spinal vertebral, this one. So this you see that the rotation, right rotation is being given and then it is massaged and then again it is put into left, this one, and then massaged. At the same time you can see that there the demand is there, that you know that you feel that it's not aligned over there. So these methods are put into SOP and then you know that it is done by the physiotherapist. We study it as those methods what have been published. But if Kerala is ready to publish all these Vaidya's methods, then we have a rich, source of information which can be of medical use. See that is Vimlavana over there. Because that sternocleidomastoid and this one which is coming here, that trapezius which is coming there, it is being very taut. Now you see that the Parsho Sandhi comes here actually. That's why it is Asti Churki, it is called Parsho Sandhi. If without knowing somebody is there, okay, I go there and give a blow there, they will immediately become bent. So that once the patient is coming there bent, then we will have to release it actually. So that's what, but once the knowledge of Marma is there, only that can be done. But we did not study like that. We studied for the Marmas for Shastra Kriya purposes only. Physical medicine purpose we should learn, and then you can see that. From the front, how you massage. Now my hand is on the Amsa. That consciousness should be there. And then it becomes very easy. In Tamil it is called Kai Bhagam, Shai Bhagam. In Malayalam it is called Kai Vazhakam. So the more you put the hand on the patients, your fingers will start talking. How the blind is able to read? Like that you will start reading this one. And thank you very much for the patient listening. If I could open out some thought from our own point of view, which is enriching our own knowledge and as well as our prestige, that is what I intend. Everyone, I again tell that everyone, it is not one person, everyone has this power in their hand. Only that whether you have a good charged battery, whether you are using it or not is the thing. You have a good light, whether you are switching it on and having the light, that is the thing. So with that, I wish you all the best. Om Sarve Bhavantu Suginaha, Sarve Santu Niramaya, Sarve Bhadrani Pashyantu Ma Kaschid Dukkha Bhag Badayat. Vishajam Sadhuvartanam, Bhadram Agamashalinam, Abhyasta Karmanam, Bhadram, Bhadram Bhadra Bilashanam. Thank you very much. Thank you very much for the opportunity.
Thank you, Srivat sir. Just to take some key takeaways from this 2.5 hours of a lot of mental stimulation that we had. If there is one thing that you saw, we as Ayurvedic doctors, we always let the therapist touch the patient. So it's very important that we also need to go down and understand it's okay to be, as a doctor, we also need to be a therapist. You know, the word therapist is also part of us. That is one thing we understand. And also this 2 hours, it is also a understanding how various techniques are there and what all we need to do here. And I remember doctor talking about this Varmam class. If you go to the website on Varmam run by Dr. Shanmugam sir in Coimbatore, if there is a possibility, please go and do a 2 or 3 day workshop. It will give you a lot of insight about which all part which doctor was showing us there. It will really help us. And another thing, if you saw, he is talking about no matter what the pain is, always understand the Rogi Bala and the mental state of the patient. This plays a very important role. Only then whatever we are doing will have the whole aspect. It's not, we are not treating the disease but the patient. So thank you, Srivat sir. I think we all need to come and be an intern at your place. That is when we will have more opportunity to learn this. So as apart from Sitaram, we want to give you a small memento. Sandeep, if you could give a... Thank you all. Now we'll break for sir, Q&A if you have any questions. If any of you have any questions, please take this opportunity to interact with Dr. Srivat sir.
Chat box. I know it is very late when the Agni is busy at some place. He will not be able to. Anyway, I guarantee that as Shastrajna, as scientists, we should be ready to interact, and Tadvidya Sambhasha is the biggest thing. Still you know that he told about me, but my colleagues like Dr. Suresh Kumar, Dr. Jayan, Dr. Matthews Joseph, Dr. Sajeevan, and those in the new generation like Dr. Jikku, Dr. Shamsu, whoever is there, now still the interaction is going on. So learning is not a ended process. Many of your thoughts maybe which was immature will get mature only by exposure. So anytime you have any questions, put it across to Aditya. Aditya can put it across to me, or if in that way, and whatever possible from our side, whichever, that's what I told, that whatever is not known, you know that in Tamil we always tell that kattrathu kayyalavu, kakkaathathu kadalalavu. So what we actually, if you see that I can give you a list of 350 Marma books, and one Janmam is not enough for that to just scan through that. So we have such a deep knowledge which we have to make it applicable in whatever we are doing. And so I always prompt that with this class, don't shut down your Marma scope, keep it open itself. And too many people kept it in the safe and treasuries only, so that after they died also, such a treasure was there, the people did not know. So now game is changed. Now whatever is there should be shared, the thought should be shared, the action should be shared. So you are always welcome whenever it is for practical purposes also. Any questions that is there, I can...
Yes, sir. Sir, thank you, sir. Thank you very much. The Marma this class was very informative. And for us, the Marma is the topic we studied in our UG classes, and we wrote the exam and we keep it in a safe locker. So this class was an eye-opener to take it out and use the Marma knowledge in our daily practice. And sir, generally we have some questions from the online session. Can you explain your experience, how we can how we can differentiate the Sama and the Avarana conditions in OP levels, sir?
Samavastha, you know that it is based on the Agni only. Sama correction is also easy, that Nirama Chikitsa, once you do the Langana itself, you will be able to achieve it. But as this Prashtavamsha is there, we know that the other Dhadus are involved. Sometimes we have to go for Pachana Dravyas, Kashayas, which are Pachana in nature, no Snehana at that time. And then when the Lagavatva of this one comes. So when the patient will tell that, we ask them whether you have, how the appetite, how the Malapravarti and the other things are there. So I always feel heavy, all this thing. Then you know that the treatment method is improving his Agni, doing the Pachana, and then going in for that. So there, you know that we don't go for more of oil therapies, Snehana therapies over there. So wait for the 2 or 3 days where you can intelligently give Eranda Thailas. So Eranda Thailas are very important over there. For Eranda Thaila is important in Avarana also. And so once it is done, the stage is arrived in 1 or 2 or 3 days. And so food is very important. So whenever there is a Samavastha, and Samavastha in the Mamsa, that is the thing I told in fibromyalgia and all the other things are okay. Even they tell that the appetite is good, all the activities are okay except the pain and the one. So there you know that it is local, that's why we go for local Pachana like Lepana and other things, and then do a Virajana. So the patients, whether some people will tell that, okay, along with the back pain I have some feverishness, jara, there is heaviness of the body, there is loss of appetite. These are the basic things which we are looking at in that. And also you see that the heaviness, the gurutvam they tell. Many patients will tell the gurutvam at that. If it is Kadi Pradesha, gurutvam of the Kadi Pradesha, etc. Where only simple Ushma Tapa Sweda is required. You should not go in for other things. Nadi Sweda is very best because you are not doing any, you put Vadahara, Avagaha Sweda, whatever is leaves which are told in Avagaha Sweda that are put, and then Nadi Sweda is given. So understanding that from that, and then, so in my practice, as you asked for this one, I usually start with first Lepana, then this type of Tapasveda, and then go for Churna Pinda Sweda. And Churna Pinda Sweda again, as in Avarana Avastha or Sama Avastha, there the differentiation is that Avaranam will be, you see that you will not expect that there, that Lakshana, but it will be there. For example, you can see that the deeper cause of Vyana Avarana, it is there, but the patient is exhibiting it in the Gati. So it is, if we simply treat it as Gancha and Pangu, it will not work. That's how it comes. Avarana is usually you find it out. For me, I have found that it is through Upashaya only. Many times it has to respond in this way, but it is not responding. Then what is there? That we will have to look into. So then in Podikiri, the Churna Pinda Sweda also, we go for either first Dhanyamla, Dhanyamla Seka, Seka or Dhanyamla Swinna Sweda, we call it. You put the Dhanyamla, the Pindas, this one in the Podikiri, Churna Pinda over the steam, heat it and then apply it. Then the second one is that you immerse it in like Shashtika Pinda Sweda and all, you immerse it in the Dhanyamla, heat it, then squeeze it, and then with that you do it. And then next only, once that comfort is come, the patient is feeling light and everything is okay, you go for oil application with elakiri. So elakiri will be with oil application done later only. So, but when you find that a patient is coming, his flexibility and pain are affected, immediately if you give, there is no samavastha, etc., immediately you go for Patrapinda Sweda itself with oil application. So that's why I told you it depends on the avastha of the patient. So Churnapinda Sweda, in my experience, I do it in 3 ways. One is first, if there is any suspense that it is there, Amavastha is there, immediately doing oil application, and Sweda with Patrapinda Sweda will be, Snigdha Sweda will be this thing, we go for Rucha Sweda. So in that, one more important thing is that sometimes you will have to go for very bulky patient with very this thing, you can go for already Snigdhatom is there, you go for Sigada Pinda Sweda or Busa Pinda Sweda, that is Manal Kiri Alangil either. Adu matram. Without even oil application, you have to do that. So usage of the Pinda Sweda, I think when Panchakarma you have learnt, you should have learned. That's why I did not explain it out.
Okay, sir, thank you. Sir, in ankylosing spondylitis conditions, your experience?
Ankylosing spondylitis condition, you have to be very careful. Again, the inflammatory stage means you will have to deal like Amavata plus Raktavada condition. Like so, all these treatments will be sidelined at that time. Only proper Pachana treatment, and a stage comes where you know that the inflammatory conditions are stalled, and then itself you can see that the patient is more comfortable. Then whatever already the ankylosing has been happened, that we can try to little give mobility, because the fuse, it will be fused, it will be going in for fusion. There the paraspinal muscles also will be. So once we are able to do Sneha Sweda and other things, the paraspinal muscles will give way a little, and this mildly mobility can be brought back to the patient. So very clearly it has to be, because it is stiffness, immediately if you go for Sneha Sweda, sometimes you will be damaging the patient. So very clearly, and every time HLA B27, if it is positive, it need not be ankylosing spondylosis. I had got from the orthopedicians 2 or 3 cases in these years where HLA B27, they declared that you are having ankylosing spondylosis, but it was not. The patient was having rheumatoid arthritis with arthritis, this one, uveitis, etc. That also will sometimes serological indices or tests will be higher. CRP may be high, this might be high. So along with those, so differential diagnosis from the lab sense, we can give suggestions for that. So once we consider that it is Ama, Vasta, Kevalavada, or with this one Rakta involvement is less, etc., then we can go for that. I did not tell about the, sometimes Rakta Visravana also is, Agnikarma I told, Vidyakarma I told, Rakta Visravana, local, now so many methods, Hijama method, cupping methods. So what has been told us, Rakta Shruti through Shringa or Jaluka, all these things are helpful in many conditions. And Agnikarma I did not detail, because Agnikarma, Shalaga Karma can be done. Now Bindu, what you call with Chaudhra Bindu, it is also very effective in many conditions. So selectivity is depending on, that's why I told that we have to go into thinking about what is there in Ayurveda, and then we can apply it.
Okay, sir, thank you. And we have completed the all questions from the online session. And it was really informative and skill development also. We are expecting more sessions with you, sir, as a hands-on training with the Aachaara Rasayana. Thank you, sir. Thank you very much. Now we are ending this first session. Now we are, the counters are open for lunch, and after that we will start the second section.
afternoon all. So we will just start with the starting period of Sitaram Ayurveda. So Sitaram Ayurveda was started in 1921 by the visionary of Maharaja Sri Rama Varma 15th. Next. So these were the four founders and torchbearers of Sitaram Ayurveda. Next. This is our current managing director, Dr. D. Ramanathan sir, Dr. Vignesh Devraj, and Srimati Jenny Ramanathan are our directors. They are the today's leadership. Next. So today we are having approved R&D by DSIR and with 500 plus classical formulations and 2 premium healing retreats in Sitaram Beach Retreat and Sitaram Mountain Retreat, and an NABH accredited Ayurveda hospital. And Sitaram Research Foundation is conducting this Aachaara Rasaayanam program for educations and global presence through a podcast of the Ayurveda Healing and Beyond. And it is one of the top 15 rated iTunes podcast, and with 480 plus franchisees. Next. So we are the first GMB certified Ayurvedic company, and these are our certifications. So we have accredited by DSIR by 2002, and these are one of 2020 by hospital accreditations, and we are also accredited by Ayush Laboratory in 2022. These are R&D. Next. So our products are heavy metal free, and all Sitaram products adhere to the international standards, and we are exporting to more than 14 plus countries. Next. So we have all the varieties of formulations, total 449 formulations. We have Kashayam tablets, Kashayam Arishtamasabam, Guliga, Lehiam, soap gel capsules, cream, soaps, and different varieties of FMCG also. So these are one of the newly launched product, this Saplin plus roll-on. We already have a Saplin plus, this is actually going good. So we have converted into a roll-on form. So this was a clinical trial we conducted on Saplin plus roll-on on myalgia. Next. So the acute myalgia affected almost 25 to 35% of the Indian population, and conventional pain relief carries risk because it will happen in any part of the life. So we converted into an roll-on easy use formulations. So the 100 participants with acute myalgia were taken, and 3 times a day application for 7 days, and VA scales and OD and PGA were used for the assessment tools. So VAs over these 7 days have a good score reductions in that VA scale, and VA scales dropped from 6.8 to 2.1 by day 7, and 73% of the reduction, and 92% of the patients were satisfied and highly satisfied by this clinical trial. So Saplin plus roll-on was provided fast and effective relief for muscle pain. Next. So the other new formulation is COPSAP SF. So the diabetes numbers are increasing in India, so we have converted our cup syrup into a sugar-free form. Next. So COPSAP is a free sugar-free Ayurvedic syrup for cough relief, combined with the classical herbs, include Deshmula and Trikatu. Next. So the organoleptic and phytochemical evaluations and TLC and GCMS were analyzed, and microbial stability were tested with this COPSAP cup syrup. These were the major chemical constants we have found: octazones and cyclohexanones, where the cyclohexanone with the major compound, 36.7% cyclohexanones were there. It is an antitussive chemical constituents, and thymol was present at 25.5%. These have an antimicrobial and antioxidant property. Next. So COPSAP is a well standardized sugar-free Ayurvedic formulations, and it is ideal for diabetic patients and those who have aversion to sugar. So the other formulation is Mashak Jal. Mashak Jal is a mosquito repellent cream. It is a mosquito repellent skin-friendly cream based on herbal formulations, and we have conducted study on kids in the age of below 12. And over 50 children were taken to the study, and durations were 15 days, twice daily application, mosquito-prone areas in Ernakulam and Thrissur. Next. So distribution efficacy grade of muscle grade A plus 25% improvement, and grade A 45% improvement. Next. Duration of repellent effect. More than 6 hours repellent effect was observed in 20% of the kids, and 4 to 6 hours in 65%, and more than 4 hours in 20%, 10%. So 82% achieved a grade A or A plus efficacy, 70% experienced 4 to 6 hours of protection, and no adverse skin reactions were reported during the studies, and 88% of parent satisfactions were reported during the study. Next. So next formulation is digestive sap syrup. Digestive sap is an appetizer and an AMA origin disease reliever. So poor appetite affects 20 to 30% of the chronic disease patients in India, leads to malnutrition, weight loss, even in kids and in even adult we can see the loss of appetite. So the product is based on Chincha, Panagam, Ashtachurnam, and is a herbal, completely herbal formulations. And it is conducted in a single arm open label pilot study with the age of 15 to 60 with poor appetite. A dose were 10 ml will given for the hunger, bowel habits, and stool consistency. So the hunger score improvement was obtained with like this. So before and after you can see the drastic change in hunger score. Next. The stool consistency are also improved. Constipated one is converted into more into normal one. Next. So the other formulation is Flexinex soft gel capsule. Flexinex soft gel capsule is an aimed for the cervical spondylosis and cervical pains. So these formulations were developed through machine learning through all the classical formulations. Next. The cervical pain from spondylosis, radiculopathy, and fibromyalgia impact quality of the life. So conventional drugs have limitation. What we have observed is that when we used even single-handedly these drugs, by 7 days the patients occurred a drastic improvement. Next. So it was an open label randomized and non-comparative clinical trial. Participant 50 patients with the cervical spine disorders. Durations were 14 days. Dose was 2 capsules twice daily. And assessment was VAS scale. Next. So there was a drastic change in the pain after the administration of this Flexinex was observed. Next. The mean pain score reduced from 7.15 to 2.2. Drastic reduction by 69.23, and 50% have achieved complete pain relief. We are also conducting an study on Flexinex on computer origin cervical pain. The study is going on. Next. So Flexinex soft gel capsule is demonstrated excellent pain reduction and were well tolerated. Combines classical Ayurveda with a modern delivery. Next one. So this is a menstrual sap capsule. This is used for dysmenorrhea. So in this we have conducted an GCMS studies, and 9 bioactive compounds pain relieving were obtained in that study. Next. So this is another one, Inflasab tablet. Inflasab is a heavy metal free pain reliever. There is no heavy metal in that, and it is based on the study inflammation symptoms including pain intensity was reduced to 1.8 to 0.26 by these products. And edema was also reduced to 0.6 to 0.06. The combination of Inflasab is glucosamine sulfate and Rasaayanam, Kashayam, Shallaki, and Gugulu. Next. That's all. Thank you.
Welcome to the second session of Aachaara Rasaayanam with the topic Emergency Management of Musculoskeletal Trauma. And we have our speaker, Dr. Kannan V, Junior Consultant, Orthopedics District Hospital, Kollam. It's my honor to introduce Dr. Kannan V, a highly accomplished and multifaceted medical professional with an impressive blend of traditional and modern medical training. Sir began his journey in healthcare by earning his BAMS degree from the Government Ayurveda College, Trivandrum in 1992. Then he expanded his expertise with an MBBS from the Government Medical College, Trivandrum, graduating in 2000. Demonstrating a strong commitment to surgical excellence, Sir completed his MS in orthopedics from the same institution in 2008. In 2010, he joined the Kerala Health Service, where he has been serving the community with a distinction ever since. Further advancing his credentials, he earned a DNB in orthopedics from the KIMS Al-Shifa, Perindalmana in 2016. Sir's unique integration of Ayurvedic roots and rigorous allopathic training offers a profoundly holistic approach to the patient's care. His dedication to clinical excellence and continuous learning continues to enrich both the governmental healthcare and orthopedics practice. Please join me in extending a warm welcome to Dr. Kannanvi. Welcome, sir.
Good evening, everybody, and thanks for the kind introduction. As the Madam has introduced me, I did my BMS from Sitaram Medical College. Started in 1992 and finished in 1998. So after that, there were two options to me, either to continue with Ayurveda or go to modern medicine. Then I got a internship at Vaid Balendu Prakash Cancer Research Foundation at Dehradun, and I was doing my I was appointed there as a research associate, and I was into a little bit of research into AMLM3 there, and I was not very convinced with the things that was going on there, and then I decided, okay, I'll jump into modern medicine. But coming here and seeing the speaker just before me, I was fortunate enough to hear the last part of his talk, and I'm very well impressed with the sea changes that has gone into Ayurveda, and I'm very happy that the outlook has totally changed, and he was describing everything with a modern angle, and that was very, very heartening to hear. Now, coming back to my topic, I know everybody will be in a state of postprandial, serotonin surge, and it will be very difficult to increase the dopamine levels. So, I think we'll go by rather than a PowerPoint presentation that I initially plan to do. I think we'll go by a discussion sort. So, see, the initial evaluation of any trauma should actually begin with the ATLS protocol. So, you should not jump into that patient, you got a Colles fracture, you're very happy, and jump into the management of that Colles fracture. The patient has to be seen in totality. This airway should be, it just takes 1 or 2 seconds. You just, after your, it's not like you have to go and see each and one, but it takes 2 or 3 seconds. You have to, go have an overview of these things first. The airway, breathing, circulation. That has to be in your mind. And second most important thing is the neurovascular deficits. Any patient, any trauma patient, however benign that trauma is, has to be evaluated for the neurovascular deficit. You have to check the pulse. You have to check the check for any neurological deficits that the patient has before managing. Otherwise, you will end up in soup. You have a shoulder dislocation, don't try to reduce it. First, see the pulse, see the neurological deficit, see if there is any deficit in the patient. Otherwise, you reduce the shoulder dislocation, the whole thing will come to you. There may be a brachial plexus injury in this patient, which will be missed because the patient will be holding the hand like this, and you won't be seeing that. After reducing the dislocation, that brachial plexus injury will come to your head. It will be branded as a iatrogenic brachial plexus injury. So always check the pulse, always check the neurological deficit, document it, and then only proceed. A short history, as we in Ayurveda say, darshana sparshana prashnahi. Likewise, a short history, how it happened. That's very, 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 very vital. If it's a medical legal case, document it. And a short history, the many things can, many clues actually can come from this short history. Like for example, a patient falling from a height, he may be complaining only of pain in the heel, maybe a calcaneal fracture, but there may be a spinal fracture. So that history of fall from height, if you not looked into the history of fall from height, you just start examining the patient, and you're happy when you see a calcaneal fracture, and you start managing it. You will always miss the other part of it. That may be a spinal injury. Also for the tenderness, swelling, deformity, and whether there is a wound or not. A wound in a trauma actually changes the whole perspective of it. Then comes investigation. Naturally, you will be knowing it for X-rays, ultrasound, CT, MRA, and the golden hour concept. The golden hour concept is after any trauma, it's a major trauma I'm referring to. After every major trauma, the first hour is the golden hour, and after that, every hour there will be a threefold increase in mortality. So a patient has to have the first aid, and the first treatment in the first hour. That's a golden hour. Now coming to the X-rays, most of us are well versed with the X-rays. It's the AP and the lateral view that we normally take, but there are many circumstances that you have to change that X-ray, and you will have to take special views. For example, for the calcaneum that I was mentioning, calcaneum needs an axial view, and without an axial view, calcaneum will be the true contour of the fracture won't be identified. And okay, so we'll start with the discussion. Anybody willing to participate in it? So for a shoulder, what sort of an X-ray will you take?
Sir, AP view.
So most of the shoulder cases, an APV will suffice, but in some special cases, you will have to take a lateral view or a shoot-through view and things like that. And what about a hand?
AP view.
AP?
AP view lateral.
AP and lateral. See, hand, if you take a lateral view, this is AP view, and this is the lateral view. Lateral view, you don't see anything. You will see the bones overlapping each other, and you won't have anything. So what's a view in a hand? Next person, or anybody else? It is an oblique view. Hand will always be AP and oblique. Okay. Now, saying that, coming to the finger, what will be the view to the finger? Normally, everybody takes AP and oblique for the hand also, for the fingers also. But for the finger, you will always have to take a lateral for that single finger. Otherwise, you will miss a fracture on the volar aspect. A small fracture on the volar aspect will always be missed with the oblique view. So it's always better to take a AP and lateral view for that finger. You will have to write right index finger AP lateral. Otherwise, you will miss small fractures on the volar aspect, which will be very, very, very vital. Then coming to pelvis is AP. Chest. What about chest? AP. Okay. You can take a AP, PA, whatever it is, and you have a, see, I'm talking about trauma, I'm talking about a case that is suspected to have a rib fracture. So what is the other view that you can take? An oblique view. Oblique view, right or left, that has to be mentioned. Right oblique or left oblique, whichever side is affected, take that oblique view. Because most of the AP view, you will not see the fracture because of the overlap. It's only in the lateral view, it's only in the oblique view that you can see the fracture. Then spine, of course, you know, AP and lateral. Pelvis is AP. Then coming to femur, what about knee? Skyline. Skyline view. Without a skyline view, you will miss a fracture on the patella. So I think that's about the X-rays. Ultrasound in a polytrauma patient, when you have a, so you are suspecting a splenic injury or some bleeding in the abdomen, you may have to take a ultrasound. And in any polytrauma patient, actually it is mandated to take a CT of the spine, especially of the cervical spine and the pelvis, if facilities are available. Most of the government hospitals, we skip that, but that is a protocol. And MRIs in some special situations. Next. So that's about the wound. You have a fracture and you have a wound in the vicinity. Then, however small it is an open fracture. It may not be just adjacent to that, but it will be communicating inside. So you have a fracture, the wound may be actually a little bit away from the fracture, but if it is in the near vicinity of that fracture, it is a compound fracture unless otherwise proved. So you have to treat that patient as a compound fracture. You have to start antibiotic as early as possible, and debridement may have to be done, will have to be done actually. So that is Gustl and Anderson classification for open fractures, type 1, type 2, type 3. Type 3 is the most severest of that, and type 3 is ABC, and type 3C is a common fracture with a neurological deficit, with vascular deficit. Next one. Management of open fractures. In the emergency, the bleeding from the wound has to be stopped. Now, you have a patient in a road traffic accident. You were just passing by, and you are the first person to give the first aid, and you're seeing a bleeding coming from the fracture site. What will you do? Pressure, where? Okay, pressure where? See, if it's an arterial bleed, you give a pressure. For example, if there is a bleeding from here, you give pressure here, it will stop. It will stop. It's just like a tourniquet. You just give a pressure on the brachial artery, it will stop. Femoral artery, or even popliteal artery, give a pressure on the adjacent artery, and massive bleeding will stop. Especially if it's an arterial bleed. That's the only thing that you can do before you rush the patient to a tertiary center where it can be managed, or to a center where you can tie a tourniquet, a proper tourniquet. And you have to take care of your safety first. Don't put your raw hand onto the wound to stop the bleeding. See, to be on the lighter side, I was doing my D-ortho, and there was a patient with a common fracture with a lot of bleeding, and he had a pretty wife. So naturally, there were at least 10 onlookers coming to help this patient, all drenched in blood, and they were causing all sort of it was a mangled leg, and there was nothing much that could be done to the patient actually, and these persons were actually causing very much problems in the casualty. And they were all drenched in blood, and they were trying to impress the wife as was obvious. And we naturally sent for the routine investigations. It came out as HIV positive. and this wife and the husband actually knew that they were positive. And they were keeping silent. And you should have seen the face of these 10 bystanders. So such sort of things can happen. So don't put your hand on any raw wound. Next slide. So X-ray views. I think we have already discussed this. Neck will be mostly AP lateral, and the neck you may have special views. For example, if you are suspecting an odontoid fracture or something like that, you may have to take a odontoid fracture. Open neck, open mouth view. Chest is AP oblique, shoulder will be AP, and sometimes in lateral view, velpulateral or something like that. Wrist, what's a true X-ray for a wrist? It's not a AP view, it's always a PA view. Even if you write a AP view, the radiographer will always be taking a PA view rather than a AP view. So they know it and they will be correcting it. Lateral, hand AP and oblique, spine AP lateral mostly. In some special cases you may have to take oblique views. Hip will be mostly AP, but in some cases you will have to take lateral, and especially in trauma and things like that, lateral view will be difficult. So they'll take what is known as a frog-leg lateral or a hanging lateral view. The knee, AP lateral, and skyline, foot is AP oblique, and the ankle is AP lateral. And of course, special views like calcaneum. Next. Bandages, to be honest, in our practice, actually, bandages have not much role, but it is mainly used in retaining the dressings, retaining the slabs. Sometimes we do it in figure of 8 bandages, especially in children, where a custom-made brace is not available. And Jones bandage for acromioclavicular joint. That's what anybody can want to demonstrate it. Jones bandage. Then for sprains, type 1 sprains, not for type 2 or type 3. Type 2 and type 3 will need immobilization. Type 1, you can put a elastic bandage, but then it's not just winding around. You will have to put a figure of 8 so that the inversion-reversion stress is also avoided. And please don't put any bandages for the elbow and things like that. It will cause vascular deficits. So vascular deficit is a problem with the elastic bandages. Don't put it too tight. Elastic bandage actually gets tight by itself. So you just have to roll it. You don't have to put any pressure on it. And for ankle and things like that, when you're putting elastic bandage, just don't roll it. Put a figure of 8. I think you all understood, didn't it? Yeah. Next. Bulky Jones bandage. Bulky Jones bandage is a special sort of bandage that we use to give compression. So, for example, if there is a persistent effusion in the knee, you have aspirated the knee, and after aspiration, it still will come within a few days. It will, fill up. So to prevent that, you will have to give a compression, and that's for those things like that, or even for oozing wound, you may have to put a bulky Jones bandage. And what you do in a bulky Jones bandage is you put a layer of cotton, not that cast padding, the fluffy cotton, normal fluffy cotton. You put a layer of cotton and then you bandage it. You don't bandage it tight, you just bandage it very loose. And then put another layer, and then you bandage it over it and this time you bandage it a little more firm. And then you put another layer of cotton over it, and that time, after the third layer, you can actually put it tight, so that won't cause any vascular compromise. So that's known as a bulky Jones bandage. That's basically used to prevent any oozing from the bleeding if the wound is going on oozing, or to prevent any effusions recollecting. Next. So the types of slab. These are basically the types of slab that we can use. Upper limb, you can use a Vola slab. What is a Vola slab? Vola slab. Vola slab is a slab put on the volar aspect. It's a short arm slab that is put on the volar aspect. And the dorsal slab is put on the dorsal aspect. Volar slabs are put for metacarpal fractures, for finger fractures and things like that. You put a volar slab basically. And for distal radius fractures and things like that, you put a dorsal slab. Then an above elbow slab. The same dorsal slab extended, or even a volar slab extended above the elbow. Coaptation splint is for humerus fractures. You start from here, come over here. You start from here and come over here. You will be having two bandages coming from here, which you can tie onto the other shoulder, and then you wrap it around. That is known as a coaptation splint. That's used for conservative treatment of humerus fractures. Humerus fractures. The first word in trauma textbooks is humerus fractures can be treated conservatively. Although the trend now is to go for surgery for most of the humerus fractures, but humerus fractures can very well be treated conservatively. Even you people can do that, and that's by a coaptation splint. Anybody wants to demonstrate? I can demonstrate. Want to demonstrate? Okay. At least 8 layers will be needed for a splint, and it will be bandaged. So, and when you take it from here, you put a bandage from here. You put a bandage from here, which can be actually tied here, so that it won't just go. So there will be a bandage coming from this side, which will be tied here, and the plaster will be extending up to this side here, and it will be bandaged. All throughout, one person will be giving the traction to reduce the fracture. That's about the coaptation splint. Then the sugar tom splint. Sugar tom splint. See, for any plaster slab, the basic dictum is immobilize one joint above and one joint below. So you have a fracture both bone. you will have to immobilize the wrist and you will have to immobilize the elbow. That is a dictum. Immobilize one joint above, one joint below. But that's not actually, followed in cases where there is a distal fracture. For example, there is a distal radius fracture. You can very well get away by immobilizing one joint, because immobilizing two joints will invite stiffness in two joints. So you can very well do it with a short arm slab. But when there is a more proximal fracture, you will have to immobilize. Or if the fracture pattern in the distal radius is an unstable type of fracture pattern, which will go into which will lose its position if the pronation supination is done. If this movement is done, and you think that the fracture is not that stable, it will not stay, and you will have to prevent the pronation supination. There are only two ways to do it. One, put a long arm slab, but putting a long arm slab, you will definitely invite stiffness here. So what you do is put a sugar tongue splint. And then thumb spike. If you have a fracture in the thumb, you extend it up to the thumb. You have to cut it actually. You have to cut it and extend it up to the thumb. That's known as a thumb spike cut. And moving to the lower leg, you have the below knee slab, below knee, above knee, and a cylinder slab. And a cylinder slab. Anterior slabs in some conditions where there is a, for example, if there is a tendo Achilles injury, if there is an avulsion fracture of the tendo Achilles, then you will have to put it in a equinus. You have to put it in a slight equinus, and then you will have to put it in anterior so as to hold that equinus. That's known as an anterior slab. Next. So plaster, this is a 15 centimeter POP. You have a smaller one that's a 10 centimeter. Then synthetic castings is there. You would have seen that, and that people walking around with synthetic plasters with the different colors. And then prelude and cast sleeves. I think in the next slide we will have that. Okay, that is a plaster slab. The first one, prelude. Prelude is a prefabricated plaster slab, a synthetic one with cotton paddings on both sides. So you can just it's readily available in the market. You just cut it. You just spray some water and put it into whatever shape you want and tie it. And it will set in 5 minutes. That's known as a prelude. Very easy to use. Then the synthetic ones. The third one is a synthetic one. Synthetic plasters actually are, the advantages are it's much, the weight is much less. And the patient it's much stronger. You can walk on that. For minor fractures like Jones fracture or isolated lateral malleolus fracture and things like that, you don't have to hop around. You can walk around. You can walk around with a synthetic plaster and it won't break. But the problem is, see, plaster of Paris, it will allow a little bit of water to go out. Even if you go to the bathroom and you get drenched, it will allow a little bit of water to go out. But synthetic material, it's made of fiberglass, so water won't leach out. So if water gets into it, then you're done. The other one is a resin, and that's the advantage of resin. Resin is a breathable material. You can wash it, you can bathe with it, no problem. So there will be a small valve will be there on one side of it. You can just put it in your hand and pump the resin it will set in 5 minutes, and after that it will be like a cast. You can even take a shower with that. Next. So when you immobilize any limb, it has to be immobilized as far as possible. It has to be immobilized in the position of function. Now, position of function for this is the position of function for the hand, because hand is the joint that goes into for stiffness very, very, very fast, and it will be very difficult to treat that stiffness. So whenever you are going to immobilize a hand, as far as possible, you will have to put it in a function of position. Function of position will be a slight dorsiflexion in the wrist and palmar flexion up to 70-degree palmar flexion in the metacarpophalangeal joint, and the fingers almost in extension or a slight flexion. Why should you immobilize the metacarpophalangeal joint especially? Out of this, the most important thing is the metacarpophalangeal joint. Why should you immobilize the metacarpophalangeal joint in flexion? You can even, the most common mistake that people do is immobilizing a hand like this. Why should you actually immobilize it like this? Because the the shape of the metacarpal head is like a round thing. So when you're immobilizing it straight, that is the shortest radius. When you flex it, that is the longest radius. So you're putting that ligaments in strain when you're immobilizing it in flexion. When you're immobilizing it in extension, it is in the shortest radius, so the ligaments will be lax and it will go into stiffness in that position. It will be very difficult to flex it after that. So when you immobilize it, put it in flexion at the metacarpophalangeal joint. Even up to 90 degrees of flexion is acceptable, because it will be very easy to mobilize the patient after that. That's an intrinsic position for the hand. That's an intrinsic muscle position actually. Knee is flexed. Knee is immobilized mostly in 30-degree flexion. An angle in neutral. There are exceptions for this. For example, I told you, if there is a Achilles tendon injury, then you will have to immobilize it in a slight plantar flexion. But it will be difficult to actually regain the dorsiflexion after that. But there is no other way out. You will have to. Next. Complications of plaster. Plasters are it's not a very simple thing. I've seen people go into amputation just because you have put a plaster. I've seen it. So it is not that it's not a thing without complications. You can have n number of complications because of plaster. I myself put a synthetic cast for a patient with a lateral malleolus fracture. In my evening practice, I did it, and next day I came to my clinic in the evening, and I was seeing the patient actually rolling around in the floor because of the pain. It got so much tight. So these are the complications that you can, common complications that you can anticipate. Tightness of the plaster. Never put a plaster in tight. In orthopedics, always put every plaster, every slab in just snug. Never put it tight. Then pressure necrosis, compartment syndrome, a dreaded complication can go into amputation. Thrombophlebitis, deep vein thrombosis because of the immobilization. If there is a lower limb, especially the lower limb, if you are immobilizing, you have to give some sort of prophylaxis for the deep vein thrombosis. Can cause deep vein thrombosis, can cause pulmonary embolism, joint stiffness, infection, loss of reduction. Okay. Next, you people will be doing a lot of skin tractions in it. So skin tractions, you know how to put a skin traction. You know how to put a skin traction. Okay, please. Tell me.
പേഷ്യൻ്റ് ലൈ ഡൗൺ പൊസിഷനിലേക്ക് എടുത്തിട്ട് ക്രേപ്പ് ബാൻഡേജ് ഇടും, എന്നിട്ട് നമ്മൾ ട്രാക്ഷൻ ചെയ്യും.
see, ഈ സ്കിൻ ട്രാക്ഷൻ എസ്പെഷ്യലി ലോവർ ലിംബ് സ്കിൻ ട്രാക്ഷൻ ആണല്ലോ നമ്മൾ ഉദ്ദേശിക്കുന്നത്. സ്കിൻ ട്രാക്ഷൻ ലോവർ ലിംബ് മാത്രമല്ല, പക്ഷേ സ്കിൻ ട്രാക്ഷൻ ലോവർ ലിംബിലാണ് നമ്മൾ മാക്സിമം യൂസ് ചെയ്യുന്നത്. അപ്പം ദ മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് തിങ് ഈസ് ടു പാഡ് all the bony prominence. Never put a skin traction without padding the bony prominence, especially just below the fibula. Adequate padding just below the fibula. Why? Just below the fibula, head of fibula. What comes there? What is the structure that comes winding around the head of neck of fibula? You have a structure coming around the fibula that can be injured if you tie anything tight there. What is that? Peroneal nerve. You can have a peroneal nerve injury. I've seen patients put on tight plaster or even bandages with the peroneal nerve palsies. So peroneal nerve palsy can happen. You can have, what will happen if there is a peroneal nerve palsy? Foot drop. It will take a long time to recover. It will recover mostly, but it will take a long time to recover. So pad all the bony prominences, pad the areas where there you have a superficial vein or a nerve, superficial nerve or an artery coming up, especially in the neck of fibula. Then skeletal traction, I think you may not be interested in that because mostly surgical. Next. So dislocations. Coming to shoulder dislocation. Okay, shoulder dislocation. How many of you have reduced the dislocation? Reduced. Shoulder. Shoulder reduced. Can be done. It's not that difficult, it can be done. It can be done by anybody. So you don't have to refer any shoulder dislocations. Give a try. What is the first thing that you have to do? No. You have a patient coming to you. It's a patient history of fall, coming with the limb supported like this. This is the limb and this is supported like this. And there is a hollowness here. Clinically, it's a shoulder dislocation. What will you do? First thing, what will you do? So, he is coming with a history of fall. He is coming with a history of fall. And he is coming with his arm supported on his other limb. There's excruciating pain. And be crying like anything, asking you to mitigate the pain as early as possible. So what will be the first thing that you will do?
And then we will start the.
What?
First we will put patient.
What was that? What was the thing that I told you when I started this presentation? Always document if there is a neurovascular deficit. Okay, so see if there is a neurovascular deficit.
It's moving. Fingers are fine.
What is known as kilonilvin sign? What is kilonilvin sign? This is kilonilvin sign. Ask the patient to do like this. You're testing all the nerves here. You're testing the radial nerve because if the radial nerve is not there, you will not be able to extend like this. You're testing the median nerve because you cannot flex without the and you're testing the ulnar nerve because you are adducting. Okay, whatever it is, you have tested the nerves now, and then you have to look into the pulse. Okay, you have to look into the pulse. There is no neurovascular deficit. What now? Never do that. Take an X-ray. Okay, no, you will be, see, you will be so confident with your diagnosis because it's very obvious. You have a hollow here. It is obviously a shoulder dislocation, and the patient is crying like anything, and X-ray will take 1 hour. Your first instinct will be to reduce it so that pain will be gone. But you're losing a document there. Who told there was a dislocation? Okay, so never, as far as possible, never try to reduce any dislocation or any fracture without documenting it with an X-ray. Document it with an X-ray. You will be in soup otherwise. It may be an MLC. You will have to prove that there was a shoulder dislocation. How will you prove? You will go to the court, and the judge and the lawyers will be, beating you around like anything. Okay, so this, and you know how to reduce this. You know how to reduce this. Okay. കിടക്കത്തില്ലേ ഇത്? See, as far as possible, don't try to reduce a shoulder dislocation in the sitting position. I know you have seen the video of L. Prakash. But the problem is, the pain will cause a vagal stimulation, and you can have a patient collapsing in front of you. ഒടിഞ്ഞു വീടല്ലേ? Okay. Okay. See, there are many methods of reducing a shoulder dislocation. There are many described techniques. I've not seen any technique like this, but you may have done it. It may be possible because, there are many methods. So, what method I follow basically is you give a traction. Because shoulder dislocation may not be that easy to reduce. It won't just go like that. Just give a traction. It's very, even with your fingers, you can give a traction like that, and abduct the limb. Abduct it. And as you are abducting it, increase the rotation, external rotation. So you will be giving abduction and external rotation gradually. Gradually, you will be giving abduction and external rotation. You will be abducting it almost full and external it full. And after that, you can just adduct and rotate. It will go in. Or even you can another method is you can just give a traction, and with one hand you can give the external rotation like this, and one of your assistant will be actually palpating the radial head, the humeral head here, and you'll just give a push and go in. Or you can even push. You can even put a towel like this. Your assistant can put a towel like this and pull it. See, this is method of putting it when you have only one person doing it. 1%. Yep.
First we start with here. First traction.
No. You stand here. Just hold the hand like this with your fingers. Okay, with your fingers, and put a traction, and then external rotation. Traction and no. You don't do it all on a sudden. It will be very painful. So just give a traction, give a traction. First you give the traction to disimpact this. Okay, see, that I forgot to tell. See, any procedure, any reduction procedure, any fracture that you are reducing or any dislocation that you are reducing, the first step will be to exaggerate the deformity. Whatever deformity is there, exaggerate the deformity. Exaggerate the deformity and then reduce. Okay, so you pull it like that, put your hand like that, slowly abduct. No jerking, no jerking. Slowly abduct, As you are abducting, you externate. You are abducting and externulating all together. Together you are abducting and externulating, and you will feel a small jerk here now. That means the head is just on the rim. No, it has not gone in. It's on the rim. It has disimpacted and it is lying on the rim here. And then you suddenly adduct and intonate. Okay, so that's one method. Another method.
And because the limb will be in a position of implementation. It's known as a slim position.
ഇതാണ് ഇയാൾ എക്സ്റ്റോണേഷൻ പറഞ്ഞത്. ഈ ഇങ്ങനെ കാല് വെളിയിലോട്ടിരുന്നത് ഇൻറ്റോണേഷൻ, ഇറ്റ്സ് നോട്ട് എക്സ്റ്റോണേഷൻ. മനസ്സിലായില്ലേ? കാല് ഇങ്ങനെ വെക്കുമ്പം ദിസ് ഇസ് ഇൻറ്റോണേഷൻ. പക്ഷേ ഫ്ലെക്സ് ചെയ്തിട്ട് വരുമ്പോൾ ഇതിൻ്റെ എല്ലാം മാറും. അപ്പോൾ ഈ കാല് ഇങ്ങനെ വന്നു കഴിഞ്ഞാൽ ഇറ്റ് ഇസ് ഇൻറ്റോണേഷൻ. അപ്പോൾ ഈ പൊസിഷനിലാണ് വരുന്നത്. അപ്പം സംബഡി ഹാസ് ടു ഫസ്റ്റ് ഓഫ് ഓൾ stabilize the hip. One person has to give a traction. Another person has to exaggerate the intonation. So stabilize the hip. അനങ്ങരുത്. താഴെ കിടത്തി ചെയ്യാൻ പറ്റും. ടേബിളിന് പുറത്ത് കിടത്തി ചെയ്യാൻ പറ്റില്ല. താഴെ നിലത്ത് കിടത്തിയിട്ടേ ചെയ്യാൻ പറ്റും. നിലത്ത് കിടത്തുക, ഒരാൾ മേളിൽ കമന്ന് കിടക്കുക, പെൽവിസ് പിടിച്ച് സ്റ്റെബിലൈസ് ചെയ്യുക. ഇത് ചെയ്ത് ഒരുപാട് PGസിന് ഡിസ്ക് അടിച്ചിട്ടുണ്ട്. ആവശ്യമില്ല ചെയ്യാൻ നോക്കണ്ട. ഇത് ട്രാക്ഷൻ കൊടുക്കുക. ട്രാക്ഷൻ കൊടുത്തിട്ട് ഇൻറ്റോണേഷൻ ആദ്യം എക്സാഗ്രേറ്റ് ചെയ്യുക. പിന്നെ കൈയുടെ ഹാൻഡ് ഡിസ്ലൊക്കേഷൻസ് മോസ്റ്റ്ലി everybody will be able to reduce it. I hardly have a call nowadays reducing a metacarpal dislocation or a phalangeal dislocation, because most of the people in the casualty itself will be reducing it, and anybody can reduce it. You people can also reduce it, but there is a dislocation in the metacarpal phalangeal joint known as Kaplan's complex dislocation, which will be very difficult to reduce it, because the head actually will be entangled between this is known as the fibrocartilaginous plate. Between the fibrocartilaginous plate, the lumbricals and the flexor tendons, it will be entangled between it, and no matter how you pull it, it won't come. You will have to open it. You will have to cut that fibrocartilaginous plate, and only that you can reduce it. So that's known as Kaplan's complex dislocation. Most of the cases you will have to actually post it for surgery. I'm not going into any details about the surgery because that's not concerning you. Next. So metacarpal fractures. Most of the metacarpal, I told you there about the X-ray. It's an oblique view, and for hand, for fingers, you can see. If you take this lateral view, you can see a fracture here. If there is a fracture here, you will miss it in this view. If you are suspecting a finger fracture, always take a lateral view. And most of those can be treated with body strapping. Okay. But now about body strapping. How do you do your body strapping? Ara, how do you do your body strapping? Obviously, it is seen in the picture. Now, what is the importance of that pad that is put in between? ഒരാൾ
To reduce friction between the two fingers or മുറിവൊന്നും ആവാതെ.
To prevent the skin maceration, so that skin maceration, but that's not the first answer. You know, what is a see, never ever strap a finger without that pad in between. That pad is having a big role. What is the role of the finger, of the pad? One is to prevent maceration, because you tie it with both the fingers opposed to each other, you will get it macerated. That's one thing, because of sweating and everything. Right? What is more important than that? See, a finger, how is the blood supply to the finger? It comes from 2 digital arteries. It comes from 2 digital arteries on either side. There is no other blood supply. So you have a finger like this and you strap it. You're actually kinking artery on both sides. Only artery that is left behind is here. So if it goes tight, you can have it very, very, very easily, especially in diabetics, it will very easily go into gangrene. So to prevent that loss of blood circulation, that's the most important thing for that pad in between. So never do a strapping without a pad in between. And it has to, you have to avoid the joint. You have to strap it above and below the joint, not on the joint. Avoid the joint. Then special types of metacarpal phalanges, metacarpal and phalangeal fractures. What is Boxer's fracture? Boxer's fracture. Fifth metacarpal. See, I would have seen at least 1,000 Boxer's fractures, and only one person actually came up with the correct story. Everybody will be coming with a history of fall. Adu thatti, idu thatti, bike പോകുന്നിടത്ത് സൈഡിൽ കൂടെ ഒന്ന് തട്ടി. നെവർ സി, ഇതെല്ലാം പറ്റുമെന്ന് വെച്ചാൽ വെള്ളം അടിച്ചിട്ട് കൊണ്ട് മതിലിടിക്കുക, അല്ലെങ്കിൽ ആരുടെയും വഴക്ക് കൂടിയിട്ട് ഡെമോ കാണിക്കാനായിട്ട് മതിലിടിക്കുക. ഇങ്ങനെയാണിത് പറ്റുന്നത്. ഒറ്റൊരുത്തും സത്യം പറയൂല. പക്ഷേ ഇത് നമ്മൾ ഡോക്യുമെൻ്റ് ചെയ്തില്ലെങ്കിൽ കുറച്ച് കഴിയുമ്പോഴത്തേക്ക് ഇത് വേറെ രീതിയിൽ തിരിച്ചു വരും. അതായി പ്രശ്നം. Boxer's fracture. Then what is a Bennett fracture? First metacarpal. Base of first metacarpal fracture. What is the difference between Rolando and Bennett? Rolando is a comminuted fracture of the base of first metacarpal, and Bennett is not a comminuted, it's only 2-piece fracture. Then what is a reverse Bennett fracture? Fifth metacarpal. Bennett, Rolando, the importance is Bennett, Rolando and reverse Bennett. The importance is they are deforming forces because of the abductors and the adductors of the thumb. The 2 pieces will be dislodged, so it needs reduction and fixation with K-wire, no conservative. Most of the cases it needs fixation. Next. Then about Colles fracture. So what is a Colles fracture? Distal radius fracture with the that is dorsal displacement and dorsal tilt with radial distal radius, dorsally tilted and dorsally displaced with the radial displacement and radial tilt. So how to reduce a Colles fracture? Colles fracture you can very well see. Naturally medical college പച്ചക്കന്നെ പിടിക്കുന്നത്. എന്നാലും theoretically പറയുമ്പോൾ some sort of anesthesia can be there, and this is a very effective method of giving an anesthesia. A simple local anesthetic injection to the fracture site, aspirating the hematoma. അത് ഫ്രാക്ചർ സൈറ്റ് ആയി എന്നറിയുന്നത് എങ്ങനെയാണെന്ന് വെച്ചാൽ അവിടെ നിന്ന് ഒരു നീഡിലിട്ടിട്ട് ആസ്പിറേറ്റ് ചെയ്യുമ്പോൾ ബ്ലഡ് വരുമെന്ന് വെച്ചാൽ അത് ഹെമറ്റോമയിലാണ്. ആ ഹെമറ്റോമയ്ക്കകത്തോട്ട് ലോക്കൽ അനസ്തേഷ്യ കൊടുത്തു കഴിഞ്ഞാൽ ആ കൈ പിടിച്ചിടുമ്പോൾ വേദന വരില്ല. ജസ്റ്റ് 5 minutes. 5 minutes താഴെ എടുക്കുള്ളൂ. 2 or 3 minutes എടുക്കുള്ളൂ ഇത്രയും കാര്യം ചെയ്യാനായിട്ട്. അത് അനസ്തറ്റൈസ്ഡ് ആവാൻ 2-3 minute കൊടുക്കും. അത്രയും മതി. ഇതിന് പെയിൻ ഇല്ലാതെ ചെയ്യാൻ പറ്റും. അതിൻ്റെ മെത്തേഡ് ഓഫ് ഡൂയിങ് ഇറ്റ്: exaggerate the deformity first. Exaggerate the deformity. ഈ ഡോസൽ ടിൽറ്റ് എക്സാഗ്രേറ്റ് ചെയ്യുക. അത് കഴിഞ്ഞിട്ട് ട്രാക്ഷൻ കൊടുക്കുക. ട്രാക്ഷൻ കൊടുത്തിട്ട് ആൻഡ് ഡിഫോമിറ്റിക്ക് എതിരെയുള്ള, അതായത് പാമ ഫ്ലെക്ഷൻ ആൻഡ് അൾന ഡീവിയേഷനിൽ കൈ വെച്ചിട്ട് സ്ലാബ് ചെയ്യുക. ഓക്കെ, നെക്സ്റ്റ് സ്ലൈഡ്. അത് കാണിക്കണ്ടല്ലോ അല്ലേ? കാണിക്കാം. യു വാണ്ട് ടു ഡെമോൺസ്ട്രേറ്റ്? Okay, I'll give a counter traction. First of all, give a traction to disimpact it, and with your fingers itself you can exaggerate it, exaggerate the deformity, and then with the finger itself, with the traction on, you reduce it, and even a pull like this, will bring it into ulnar deviation. So exaggerate it, reduce it, and then the position of immobilization will be in palmar flexion and ulnar deviation. Okay, in this position, yeah. To give the traction. Exaggerate the deformity. No, you don't have to move this. At all. You are giving a traction. You're giving a traction with this, and with the finger itself, you are exaggerating the deformity, reducing it, and then with that, then after reducing it, you can hold it here. No. Hold this. And hold this. Okay. Hold the thumb, and put it in ulnar deviation. Put other person will be putting the slab, and it will be immobilized. Okay. That's how to reduce a colies. Okay. Next. So a little, So for the distal radius, the acceptable, after reducing the distal radius, and you will see the reduced X-ray, then you will have to see if all the parameters for the radial inclination, radial length, and the palmar tilt has come up in the check X-ray. Then only you have to accept it. Okay, and coming to the distal radius fracture, the wrist X-rays, you will have two lines, this is known as Goulet lines, and these two lines should be parallel. There should not be a space here. This space should be normal. There should not be any increase in space here. And what does that signify? If there is an increase in space between the scaphoid and the lunate, what does that signify? There is an increase if you have a trauma. If a patient comes with a trauma, with a wrist pain, there is no fracture in the X-ray. The only thing that you see is the increase in space here. So what is it? That's a disruption of the scapholunate ligament. Scapholunate ligament. That is known as Terry Thompson sign. Heard about Terry Thompson? Terry Thompson is an English comedian. And he has a increased space between his, between his teeth. So that is why it is known as Terry Thompson sign. And these two lines should be parallel. Otherwise, you will be suspecting a dislocation of the carpus. And in the lateral view, the lunate and the capitate should be, this is like a cup, and this should rest on the cup. And the lunate should be vertically aligned. It should not be aligned volar, or it should not be aligned dorsal. What if it is aligned volar? What is a condition called? You have a lateral view of the X-ray, and the lunate is tilted like this. What is that called? That is called a volar intercalated segmental instability of the wrist. And if it is tilted like that, it is known as a DC, dorsal intercalated segmental instability. Those two things is it's easily missed. Better don't miss it, because you will be seeing the X-ray and you will be sending the patient with nothing, maybe an elastic bandage, and his pain won't go like that. So it's known as a VC and a DC, volar intercalated segmental instability, and a DC. That is seen in a true lateral view. That view has to be true lateral view. You can see that. Okay, next slide. So that's distal radius fracture, Colles fracture, and that will be how it will look after reduction. So the dorsal tilt and the radial tilt will be coming back to position. Now, even if you immobilize this patient like this, especially in a osteoporotic, in an old osteoporotic patient, the final X-ray may look like that. That is because of subsidence. The wrist can go into subsidence, and there will be a positive ulna variance. The ulna will not be in the same line, and that can cause pain with supination pronation. You may have to do what is known as a Dirac resection for that later. Next. Okay, the X-ray, this clear. Can you see the fracture here? What is that fracture called? That's known as a Schoffer's fracture. Schoffer's fracture. And what is that? The distal radius is angulated volar. So what is it? Smith's fracture. Next. So different sorts of distal radius fractures. Next. Okay. So that's what is this fracture? So volar button. That's known as a volar button. You have a fracture of the volar aspect of the distal radius with the subluxation of the carpus volar. This is not amicable for conservative treatment. Don't try to reduce it and put plaster. It has to be operated. And again, this is a scaphoid fracture. Complication of scaphoid fracture. Avascular necrosis. Avascular necrosis non-union. Non-union avascular necrosis. And later, if it's a non-union, it will go for a scaphoid non-union advanced collapse, SNAC. Or malunited, it will go for a scapholunate advanced collapse. It will end up in arthritis basically. Okay, next. That is the last one was a previous. The last one was a It's a peri. What is the problem with that? No problem. Gap. Where? Don't miss this. It's a very, very, very obvious thing. It's an empty teacup. Empty teacup. What is it? Capitate is not seen over the lunate. So it's a perilunate dislocation. It's a dislocated. What you're seeing is a dislocated lunate. So it's a perilunate dislocation. Needs immediate reduction and sometimes fixation. Next. And spine fracture. Spine fracture. So what will you do if there is a spine fracture? If you are seeing a patient, if a patient comes to you with a suspected cervical spine fracture, what will you do? Look for neurological deficit. Look for neural deficit. There is no neural deficit. You take an X-ray, document if there anything is seen in the X-ray. Mostly nothing will be seen in the X-ray. Take a CT and document the fracture. And how will you immobilize it? That's the question. You're going to refer it. Anyway, at your level, you're not going to treat a spine fracture. You're not going to treat a cervical spine fracture at all. You will be referring that patient. How will you refer this patient? Will you just ask the patient to go away like that? No. Cervical spine. Cervical spine. It's a cervical spine. It's a cervical spine. How will you immobilize the cervical spine? Patient came walking to your casualty, walking to your OP. You don't have to. You don't have to put see what you're talking may be right in technical terms, but in our terms, you can't ask a patient who just walked into a casualty to call a ambulance and go. So how will you actually immobilize this patient? What sort of collar? Always put a Philadelphia collar. Okay, that thing that you're seeing is a Philadelphia collar. Okay, so cervical spine injury, no soft collar, no hard collar. It will not immobilize. Don't send the patient with a soft collar or a hard collar. Always put a Philadelphia collar. You will be prone for litigation if the patient ends up with neurologic deficit after you have diagnosed it as a cervical spine injury and you have not properly immobilized. And second thing is how to do a log roll movement. One person will be stabilizing the cervical spine. This is for a field. If you are in the site of an accident and you have to shift the patient, this is how to do a log roll movement. One person stabilizes the cervical spine, and the other person will two persons actually. One will be holding the shoulder, and one will be holding the hip. Will be rolling it. Even if there are only two persons, one person stabilizes the cervical spine, the other person holds a shoulder and the hip and rotates like that. So that the spine will go in one piece. Then even you can put the brace that you're seeing there is, what is the name of that brace? This one. I'll tell you the context. A person has come to your OP with a history of fall from height. You took an X-ray. There is a spine fracture, and you want to immobilize this patient before sending to the next center. What is the brace that you will put? That is known as a Tailor's brace. This is available in most of the medical stores. So, big medical stores anyway will be having that. That is known as Tailor's brace. Okay. And next. Now coming to the pediatric trauma. Pediatric trauma, this is the physeal injuries. Physeal injuries, see, a child coming with a history of fall, and there is a tenderness on the physis, on the distal radius or whatever it is, on the physis. It should be treated as a physeal injury. What is the importance of the physeal injury? What is the importance of the physeal injury? Physis is growing part. It's a growing part. It can cause growth arrest. So that is importance. That's a classification for Salter and Harris classification. Ogden has actually increased the classification to 3 more classifications. This is Salter and Harris. Okay, next. Again, supracondylar fracture. Supracondylar fracture type 1 you can easily treat with a slab. No need for any other thing. Just put a long arm slab. You can treat it. Type 2 you have to reduce it. Type 3 you will have to fix it. Next. And previous. Okay. There will always be an overlap. This, when you look into the lateral view, the head should actually overlap and come here. If that overlap is not there, it is a supracondylar fracture. And there will be a hematoma. There will be a hematoma forming here, and there will be 2 lucencies seen in front and back. That will also be an indirect sign that that there is a type 1 supracondylar. Type 1 supracondylar is not fully seen in an X-ray. Mostly it is a clinical diagnosis. Next. Pulled elbow or nursemaid's elbow. So how will you reduce a pulled elbow? History is a trivial fall. A child of 3 or 4 years with a history of trivial fall, coming with a not moving the elbow, not moving the hand at all. How will you reduce a pulled elbow? It can be reduced in 2 minutes. It can be reduced very easily. How will you reduce it? Simple thing. Just put the hand in full supination. Put the hand in full supination, and just flex it. That's all. It will get reduced. Full supination and flex. No need to immobilize the patient. You can just send off with a chocolate. That's how it is done. You reduce it. The child will be crying like anything. You want to check actually it is reduced or not. You don't have to take an X-ray, because first of all you won't see this in the X-ray. So there is no need of a check X-ray also. So you want to know whether it is reduced or not. You will get the click. But sometimes you won't get the click. So how will you confirm? Ask the mother to go buy a chocolate for the child and come back after 5 minutes. The child will be very happy and moving the hand. Next. Okay. No. This is from my own hospital, and this actually came to me yesterday night. So she had a history of fall, some 1 month or more than 1 month, treated in my hospital. The house surgeons had actually treated it, and this is the fracture. Can you identify the fracture? What is the fracture? Fracture? Fracture P1 index. Okay. Oh, sorry, ring finger. Okay. Fracture P1, ring finger. Okay. So what will you do? Body strapping. Next slide. This is what he or she did. It was a body strap from the casualty. House surgeon also wrote continue body stepping, and wrote some medicines and review after 1 week and things like that. And this process continued 4 weeks. 4 weeks. Next slide. This is the condition. The fracture is almost healed. I mean, the last X-ray that you saw was done only a couple of days ago. So even in that X-ray, the fracture is healed. And this is the condition of the hand. Happy? Happy. Next slide. This is the condition of the hand now. You know what happened? Now you can understand what happened. So all innocent looking fractures are not innocent at all. This fracture had a rotation. This fracture had a rotation. This fracture had a rotation, and that rotation will not be seen in the X-ray. You will have to flex the limb and see the rotation. This is known as a cascade. This one is called a cascade. You have to see the finger cascade. You have to see the finger cascade before body strapping. If you don't see the finger cascade before body strapping, and in a busy OP just write body strapping and leave it, this will be what happen. This will what happen. Now it's 6 weeks post-op. 6 weeks after fracture. It's almost fully united. What will you do now? Previous. Even in the previous one, actually in the you can appreciate a little level of rotation in the thumb. You can appreciate that, but it needs a little bit of observation to see that. But if you miss this thing, I posted this case for Monday. So what will you do? What will be, at least suggest me, what will be my plan of action? What can I do now? That is known as osteoclysis. Give an anesthesia, do an osteoclysis, break the bone and restrap. That is, but see, it's already 6 weeks. It's not that easy to break that bone. Sometimes it won't come. And in that condition, see, if you have seen this patient at 2 weeks, it will be very, very, very easy. It will be just like a plastic. You can just mold it and it will stay in that position. 2 weeks, 3 weeks, it will mold and it can stay in that position. After 6 weeks, it will be bony callus now. It's not that easy to break it. And if it is not coming, you'll have to open it, you'll have to osteotomize it, and you'll have to fix it with KYs. Okay, next. I think I have finished. Next. Okay. So I have deliberately left out all the surgical part of the trauma. Only the conservative things that may be interesting for you. That's all that I have picked up. Any doubt or? Okay. The organizers actually asked me to demonstrate how to put a plaster slab. So, anybody volunteering? Plaster slab. Plaster mukkande. You're very much interested in ortho. Yeah. We have to have one victim also. You can call your friend. You're a victim, madam. Pastor. That I already. my side. Actually, this is all that is enough. Okay, you need this one. First of all, this is the plaster slab that you have. You have the cast padding. So the things that we will need for putting a slab. One, we will need a a roll of plaster. For a short arm slab, you need only one. For a long, you need 3. For leg, you need for a below knee, you need 3 or 4, and for a above knee, you need 5 at least. So we are doing only a short arm. So you need a roll of POP, a roll of cotton, and bandage. Okay. Shut. Okay, other one to leg. Okay. What will you do? We'll take the length first. So she's taking the length of the limb for the short arm slab. It has to extend from the metacarpophalangeal joint on the dorsum. Metacarpophalangeal joint from here up to here. This is all that is needed. Okay, so you have to measure that. This is the length that you are going to take. Okay, now take multiple rolls for multiple. Keep it here.
It was a very nice session by doctor. I think everyone enjoyed it and everyone was interactive. Even though it was a post-lunch session, everyone was interactive. But no one put forward to do these things. The doctor was inviting so many times. Anyway, maybe next time they will come for that. It was a very informative session, and I think from my Shalyam classes, I gone to that time of fractures and everything. It was a very nice session. And thank you, doctor, for a wonderful session. And on behalf of Sitaram Ayurveda, we would like to thank you for this opportunity.
Now I invite Dr. Aditya Panikar to present a memento to Dr. Kannan as a token of love and appreciation from Sitaram Ayurveda. To deliver the vote of thanks, I'm inviting Rube sir, GM Sitaram Ayurveda.
Good evening, respected doctors. I take this opportunity to thank each one of you for the effective participation for Aachaara Rasaayanam, the Aachaara Rasaayanam 241, a CME initiated by Sitaram Ayurveda. All of us know the CMEs are the most useful opportunity to improve the knowledge and clinical experience to enhance your practice. I take this opportunity to thank our respected director, Dr. Vignesh Devraj, for inaugurating the session and shared his inputs about Ayurveda. On behalf of Sitaram, I would like to thank Dr. Sivas, respected Dr. Sivas, for a wonderful session about comprehensive management of low back ache, sciatica, and cervix spondylosis, a practical insight into Marma therapy. A sincere thanks to respected Dr. Kannan V for a wonderful session about emergency management of musculoskeletal trauma clinical assessments, hands-on training in bandaging techniques and X-ray interpretation. A special thanks to our CGM, Mr. Sandeep, for his participation and guidance even his busy schedule. Thanks a lot for Dr. Aditya and team for the new launches as well as the evidence-based and the evidence-based products with clinical studies which definitely help us to enhance your practice and offer better cure for your patients. Once again, thank you very much for the participation, and special thanks for the entire Sitaram crew for making the program a great success. Thank you, thanks a lot.